make the joints a little sore, so just feel free to move around and feel comfortable. The parking, if you hadn't gotten parking validation, we do have parking validation for you. And how that will work is you just put in your ticket that you got with parking, and then you scan the code on the ticket, on the parking validation ticket that we gave you. And the scanner is like kind of pointing down. So just in case you put it under, you'll see like a red line. I know a lot of you were asking about that, so I just wanted to clear that up. If you have any more questions, let me know. Bathrooms are right around the corner near registration. Feel free to get up anytime and to use the bathrooms. This meeting will be recorded, and I will also be taking some photos, if that's okay. And we will, might post them on our social media. This meeting, virtual attendees, hello, all of you. Please input any questions you have in the chat. We will be monitoring the chat. The chat function is usually on the bottom. If you need to hop on or off or accidentally get kicked off, just use the same link and you can get back on. And most importantly, post-event, or actually at the end of this presentation, we have a QR code for a post-event survey. And we will also send that to you via email. Please make sure to fill out that survey. It really helps us inform future educational events and symposium. And we really want to know how you felt about your experience today. I want to say a big thank you to our sponsors. We have Merck, Novartis, Bristol Myers Squibb, Pfizer, Genentech, Castle Biosciences, Iovance, Biotherapeutics, and Regeneron. We could not host these amazing events without our sponsors. And so if you see any of them today, please thank them. And I want to give them also a big thanks as well. So I'm just going to tell you just a little bit about the MRF, and then we'll get into the main part of the program. MRF was founded in 1996 by Diana Ashby, who was diagnosed with melanoma, and after a 3-year battle, found that there was no options, or very, very few options, for new therapies and clinical trials. And that is a picture of Diana and her husband. The mission of the MRF is to eradicate melanoma by accelerating medical research while educating to and advocating for the melanoma community. So we have our 3 pillars are education, advocacy, and research. And you are here at an education event right now. Here's a little picture, some pictures. This is our footprint today. We have events all over the country. We have 19 5Ks in cities all across the United States. We host 2 signature gala events each year. We do 6 or 7 patient symposiums each year. We bring patients and caregivers to DC to talk with congressional leaders about what is needed and why more funding is required for melanoma. We also have pediatric or young adult events that we host each year. And we host a patient symposium for the rare subtype community as well. In fact, next week in Boston, we are hosting a patient symposium on ocular melanoma. This is our research portfolio. It's actually being updated right now, but this gives a snapshot of the research we are funding. We have given 31 grants in 2023 and have given awarded over $25 million in research. Our education, this is what we do. This is our education pillar. We have a ton of amazing resources, and I'm just going to go over them quickly with you, but we have webinars, we have animated patient videos, we do patient caregiver symposiums, We have education on rare subtypes and so much more. And these are some of our educational materials. So if you go on our website melanoma.org, and then you go to education, and then you click on Education Institute, that's how you'll get to our Education Institute, which includes a learning platform, our education materials, and that's also where you can find a link to the animated patient videos. This is just a snapshot of some of our materials. We have 26 pieces of literature available. These are all free to download or free to, you can also order them. If you scroll down to the end of our page where the education materials are, you can order them for yourself. You can order them for clinics. We send them to schools when they have events across the country, all free. And we have, as I mentioned, tons of educational materials. There's also, here's some more of them that are available. And you might see them at your offices because we do send them to doctor offices all over the United States. So maybe sometimes you might see some of these. Our animated patient videos, these are really great. I always recommend these to, if you want to send them to loved ones who want to learn a little bit about what you're going through, a little bit more about melanoma. They're usually just about 10 minutes long. They're very short, easy to understand. Currently we have 6, but we are creating a new one this year. On mucosal? Oh, immunotherapy, sorry. We also have a learning platform where you can find all of our past symposia courses. We have past all of our webinars. We do one webinar a month. I'll get to that in a moment. And we have our Melanoma Educator course. So there's 64 on-demand videos in these different categories, and those are also free to view anytime. As I mentioned, we host an Ask the Expert webinar once a month on different topics. And we usually include an expert and then a patient because we always want to hear the patient voice. In fact, if you're interested in ever being a part of one of our Ask the Experts, please reach out to me anytime. We also have a patient and community forum. This is a way that patients, caregivers, family members, they can talk to each other about the experiences that you're going through. We have topics such as new therapies. We just have a big one on TIL therapy. We talk about rare subtypes, how to handle grief, lots of different subjects. Or you can start a new post if you want to talk about something. But this is a great way for patients and caregivers and family members to kind of, feel connected with other people that are going through the same things they are. Or to ask questions about new therapies that they're thinking about. As I mentioned before, every year we bring patients and caregivers to the Hill to meet with congressional leaders. We also work with legislators and policymakers to help increase funding for cancer and especially melanoma research. We just held our annual Advocacy Day last month, but if you would like to attend our Advocacy Day next year, please reach out to me and I can connect you to our advocacy director and make sure that we get you on that list to attend next year. We have several prevention and awareness campaigns. In fact, we will be announcing our new spokesperson for the Get Naked campaign next month, which is really exciting. I can't give any hints about it, but on May 1st, we'll be announcing that. So keep an eye out for that. Last year, it was Teddy Mellencamp, daughter of John Mellencamp, that picture right there. May is also Melanoma Awareness Month. So we have a lot of amazing things that we will be coming out next month, including an Instagram and TikTok filter. So if you're on TikTok or Instagram, or if your family members are, make sure they keep an eye out for that. We also have our I Get Dilated campaign and Spot the Dog campaign for pediatric melanoma awareness. and we have the Out of the Shadows campaign for mucosal. We also have some cutting edge programming that we're working on. We have our CureOM's Vision Platform, Breakthrough Consortium, and Mucosal Melanoma Initiative. You can find out more about any of these programs on our website, so please feel free to check those out if you're interested. If you want to know more about what's going on or any of the things that I just mentioned, I do encourage you to follow us on social media. We're on all the platforms. You can find all of our links right here. And that way you can get, up to date on any events that we're doing, any campaigns, and you'll get to see who our Get Naked spokesperson is on May 1st. We also, as I mentioned before, we host miles for melanoma across the country. So we actually have one coming to Chicago on July 21st. This is a family-friendly event. We host these all across the country. And so the one in Chicago is July 21st. They have a really family-friendly atmosphere with a variety of industry partners present and a board-certified dermatologist that provides complimentary skin checks for all participants. We are in partnership hosting a webinar next month with the American Brain Tumor Association. There's a table out there. We encourage you to please get some literature from them as well. And if you're available to join the webinar on May 9th. And then lastly, I just want to say, we are a nonprofit and we're dedicated to advancing the scientific understanding and treatment of melanoma, and every individual contribution is vital to our mission. We do offer a variety of ways that donors can engage and contribute to the cause, whether it's participating in one of our inspiring events, such as the Miles for Melanoma Runs or our national galas in Denver or New York. Or through any of the community fundraisers. Your support is critical to our mission. And for those who prefer direct contributions, our online donation platform provides a seamless way to give. Each mode of giving ensures that together we can continue to fund vital research and support services for those affected by melanoma. And every dollar is important to us. Doesn't matter the amount, we appreciate everything. Again, I want to thank our wonderful, wonderful sponsors who are helping us host this event. Without their support, we really could not do the amazing work that we do and host these functions. As I mentioned, I'll put this up at the end of the symposium again, but this is a QR code to our post-event program evaluation survey. You can just put up your phone and kind of scan that code. Again, I will also put it up at the end, and again, we will follow up via email if you prefer to just do it, click on the link via email. Thank you for your time today. We're excited to get the program started, and I will be in the back there if you have any questions. We also have Miriam over here, and we have Janelle on the registration table. If you have any questions or any concerns, please come up to us anytime. Thank you, and let's get the program started. Of our inspiring events, such as the Miles for Melanoma Runs or our national galas in Denver or New York, or through any of the community fundraisers. Your support is critical to our mission. And for those who prefer direct contributions, our online donation platform provides a seamless way to give. Each mode of giving ensures that together we can continue to fund vital research and support services for those affected by melanoma. And every dollar is important to us. Doesn't matter the amount, we appreciate everything. Again, I want to thank our wonderful, wonderful sponsors who are helping us host this event. Without their support, we really could not do the amazing work that we do and host these functions. As As I mentioned, I'll put this up at the end of the symposium again, but this is a QR code to our post-event program evaluation survey. You just put up your phone and kind of scan that code. Again, I will also put it up at the end, and again, we will follow up via email if you prefer to just do it, click on the link via email. Thank you for your time today. We're excited to get the program started, and I will be in the back there if you have any questions. We also have Miriam over here, and we have Janelle on the registration table. If you have any questions or any concerns, please come up to us anytime. Thank you, and let's get the program started.
Good morning, everyone. My name is Jennifer Choi. I'm one of the dermatologists here at Northwestern on faculty who specializes in melanoma. I see some of my dear patients here, and I'm so happy to see you. But we're going to start off basically with knowing how to detect melanoma of the skin, and sort of what can you do to look out for spots on your skin? How can you help a family member looking for certain spots that are suspicious? So we'll go over these basics. Okay, let's see. Okay, so some kind of just very basic. So what is melanoma? So it's a cancer arising from melanocytes. Melanocytes are the cells that produce melanin, which is the pigment found in skin, eyes, and hair. Oh, what happened? Okay. And it accounts for only 1% of all skin cancers, but unfortunately it accounts also for the large majority of skin cancer-related deaths worldwide. It's the most serious form of skin cancer. It's the 5th leading cancer in men and the 5th leading cancer in women. And the American Cancer Society estimates that this year, over 100,000 new melanomas will be diagnosed, more in men than women. And approximately 8,300 people are expected to die of melanoma, also more in men than women, and approximately 1 person dies per hour from melanoma. It is more common in patients with light skin. So in Caucasian people compared to African American or Black patients, the lifetime risk for getting melanoma in Caucasian people is 2.6%, so 1 in every 38. In Black people, it's 1 in 1,000, and in Hispanic people, it's 1 in 167, and that's also about the same in Asian people. The risk increases as people age. The average age is actually 65 years old, but it's also important to know that this is a young person's cancer as well. So it's the most common form of cancer among young adults aged 25 to 29, and the second most common in age 15 to 29. In terms of the risk factors, one of our faculty members, Dr. Garami, is going to go over all the genetic factors, but just know that there are genetic risk factors, environmental, and then also how those genetic factors interact with the environmental factors. So when it comes to environmental, one of the most important risk factors is exposure to ultraviolet light. That includes sunburns and intense intermittent sun exposure. So there is some evidence that patients who are like outdoor workers, always exposed to the sun, like construction workers, are actually less at risk than those who work in the office and then go on vacation and get sunburned. So it's actually that intense sunburn that can actually be more of a risk factor than even overall cumulative sun exposure. And it has been shown that just 1 blistering sunburn in childhood or adolescence more than doubles a child's chances of developing melanoma later in life. So all of you with children or grandchildren, it's so important to educate them now and to ingrain it in them now that this is something that is a lifestyle thing to do sun protection. Melanoma is also more common in residences closer to the equator. And then also tanning beds have been classified as a World Health Organization classified carcinogen in the same category as arsenic. And it has been shown that a first exposure to indoor tanning before the age of 30, they have a 75% increased risk of developing melanoma that individuals have had no exposure to indoor tanning. So thankfully, we're seeing fewer and fewer people do indoor tanning. Go back to the 80s and 90s, it was terrible, but people are still doing it. So it is still out there and people are still doing it. And then when it comes to gene-environment interaction, so some people have a natural, partly genetic and also partly from a lot of sun exposures, they just have a lot of moles, where some people have very few moles. And so the increased number of total moles you have, even if they're completely benign, is actually an independent risk factor for melanoma. And then if somebody has multiple atypical moles, so all of their moles actually look like irregular borders and different colors within them, but they're not melanoma, then that also is a risk factor for melanoma. And then having a large birthmark actually does confer risk for melanoma. And then having freckles actually is a risk factor. And then a personal history of melanoma, it does increase your risk of getting a second melanoma. So that also is something to keep in mind. Now, in terms of what it can look like. So what can melanoma look like and what do I look for? As in you, and also what I look for as a dermatologist. So you may have heard about the ABCDEs of melanoma. So basically, this is a good framework to keep in your mind in terms of what to look for, anything that's obvious on your skin. So asymmetry means that one half is unlike the other half. B means when you look at the borders, they're irregular. They're not perfectly round or oval. They can be scalloped. One part, there's this little part that's jutting out. C stands for color, meaning within a single lesion, you see multiple colors. So it's not just all one color. There's one part that looks white, another that looks black, and a part that looks pink. D stands for diameter. So while melanomas are typically great, well, actually, so they say look for lesions that are greater than 6 millimeters, which is the size of a pencil eraser. And those are spots that you want to keep a close eye on. We do diagnose melanomas that are definitely much smaller than that. But that's something for you to look for. And then E stands for evolving, and this may actually be the best one for you to look for. So anything that you feel like is new, changing, growing, bleeding, itching incessantly all the time, something like that, that to you is just different and changing. That is something to come, have checked out. Now there are different, I'm gonna show you pictures of what some melanomas look like. So there are actually different types of melanoma. So the most common type is what we call superficial spreading melanoma. This accounts for 60 to 70% of all melanomas. They occur most frequently between the ages of 30 and 50. They can occur at any site, although it is common in lower extremities of women and in the trunks of men and women. And also they're common on the head and neck area. So when you look here, these have the ABCDEs. So you look at, this one, this kind of looks darker. You can almost imagine that you can see that there's a darker spot here and a little bit pink in the middle. You can see here that this one definitely has irregular borders. There's this part that's clearly going out like this. And then not only that, you're seeing irregular colors within the lesion. This part is darker. You're looking here where there is some irregularity to the border, but actually what's more concerning is the C part, is that there are different colors within it. So this looks very black, while this looks, you can see that this border actually is part of the lesion, but it's light brown. And then in here, it's looking lighter. And then this one also, even though the borders aren't super irregular, there's this color variation where this part is very dark and this part is looking pink, and there's almost a light brown part here. Here are other photos of melanomas that I have picked up in my own patients. So again, you're seeing irregular borders and color variation. This one, there is border irregularity, and there's definitely darker discoloration right in the middle. There's lighter on the edges, similar here. This one shows you how it can actually be tricky. This is a patient who had melanoma, and then she had recurrent melanoma that looked like a pink scaly patch that was coming from the scar. And so because as a dermatologist, I knew what to look for, we biopsied this, and this was recurrent melanoma. But again, it would be the evolving factor for you to notice. This is new, it's near my melanoma scar. Is this normal or is this not? And then you can see, I'll talk about dermoscopy, but this is a very special tool that we use in the office where we can see details that you can't see with the naked eye in terms of color and network. And so underneath the dermoscopy, you can see very clear color changes. And then in this one as well, where you can almost see that in the middle of this melanoma, it looks like there's a scar forming, even though no procedure was done, but it's all from the active melanoma cells. Now, nodular melanoma is another one to be aware of. It accounts for fewer percentage, so only 15 to 30%, and they most frequently occur in the 6th decade of life. They also can occur in any site, but most frequently on the head and neck area and the trunk. And then these are actually, again, in this type of melanoma, the E is the most important factor, the evolving, because a lot of these melanomas don't have the A, B, C, or D. So this is a picture of one that basically looks very dark and black, but it's pretty much one even color and it looks perfectly round. But this would show up as like a black dot and then it would pretty rapidly be growing. So within like 3 or 4 months, it's going to be double the size. This is what a nodular melanoma is going to behave like. So E is going to be like, there's a new spot, why is it growing so fast? Here are pictures of other nodular melanomas. And so again, you can see they don't so much have the the ABCDs, but you know, they look kind of, these will definitely be more nodular. So like rounded, like a nodule. And then they oftentimes will just be growing quickly. These can be mistaken for cysts too. So, you know, we have seen amelanotic melanomas, melanomas that are pink or red. People think that they're a cyst or a pimple. Again, it's not going away. Why is it growing? And now why is it bleeding? Like that's something to go in and check. A next type of melanoma is lentigo maligna melanoma. So these occur in they count for 15% of the melanomas that we pick up, and they're most frequently in the 7th decade of life. They occur on chronically sun-damaged skin, most commonly on the face, including the nose and cheek. And then 5% of these can actually progress to invasive melanoma. So these are the ones that you're going to see, you know, in patients who are older and patients like in your grandparents. And basically they can look like and show up as a sunspot that has been there for years. So sometimes a sunspot will be there in your 50s, 60s, 70s, and then all of a sudden it starts to change. And this is what you're going to look for. Basically, instead of just like one brown spot, you're going to start to see also color changes within the lesion. And here you can see clearly that, you know, within brown, there's this darker area that's going to be pretty slow to show up. So sometimes patients don't notice it, and then a family member they haven't seen in 6 months will be like, that looks different. Like, did you have that checked? Here are all examples of also lentigo maligna. So these are all sunspots that started and slowly changed into melanoma over years. And then these are examples of lentigo maligna melanoma, where the lentigo maligna, which is just in the surface of the skin, can actually become invasive. And in those cases, you'll see that within the patch, like nodules will start to form. Okay, and then the last one to talk about in terms of the most common types is acrolentiginous melanoma. So this occurs when melanoma occurs on the palms of your hands, the soles of your feet, or in your fingernails. And this occurs frequently in the 7th decade of life, although we have seen it in patients much younger as well. It only accounts for 5 to 10%. The incidence is similar across racial and ethnic groups, but it represents a disproportionate high percentage of melanomas diagnosed in Black patients. It accounts in up to 70%. Up to 70% of melanomas in Black patients will be acrolentiginous melanoma, and in Asian patients up to 45%, because the incidence of the other melanomas are less frequent. And so this is part of our public education, is that even though they're not as high risk for the superficial spreading that we saw first, that we have to tell our patients to check your nails, check your hands and feet. And it has also been shown that this type of melanoma is associated with a worse prognosis because either it's not noticed, it's thought to be something like a bruise or a wart, and by the time it's picked up, it's already advanced. So here are some other examples. This is on the bottom of the foot, and you can imagine we're not always all looking at the bottoms of our feet, but this was a melanoma that was picked up when it was finally noticed. These are all examples of acrolentiginous. This patient, it was mistaken for a wart for over a year and treated by a podiatrist, and because it wasn't growing, because it wasn't healing, it was finally diagnosed as melanoma when it was biopsied. It can show up as streaks in the nails as well. And you can see on this one, there's even a little nodule here at the bottom of the streak. And so when it shows up as a streak, you actually want to watch for signs that are changing. So if it starts to get darker or if it starts to spread out in diameter. So streaks in the nails, believe it or not, are actually common and benign. So moles occur, like benign moles occur all the time in our nails, but it's when it starts to change that you want to seek attention. This patient, you can see it probably started off as like a streak, but then it ended up taking up the entire nail. And then you can see that the pigment is now spreading onto the skin of his finger. And then these are more acral lentiginous melanomas that occur on the bottoms of the feet. And these are not related to sun exposure, as far as we know, right? Because you're not exposing your feet all the time. So these are less associated with the UV exposure. And then here are examples. So this is one that was shared on today.com on the Today Show. This patient who had this streak in her nail that slowly started to spread over time. She sought attention. It was a melanoma in situ, so thankfully it was stage 0 by the time it was diagnosed. And then this patient where she started off as a thin streak and then it started to grow. And then she actually got a pedicure and she ended up having an infection of her nail bed. But when she went to go see a doctor, that doctor was the one that said, we actually need to pay attention to this. And it was melanoma. Here are pictures, just for sake of time, I'm going to go through this. So AAD stands for American Academy of Dermatology, and if you go to aad.org, they actually have some really nice information, but this is basically showing pictures of melanoma in other ethnic groups like Asians, African Americans, Latino patients. And then this is important. So there's this great initiative called See My Skin, so seemyskin.com. And this is really nice because it specifically shows you examples of different diagnoses in skin of color. And so this is also really important. And again, the acral lentiginous being common in skin of color, we want to increase awareness of this. And then again, I mentioned amelanotic melanoma, where it cannot just be black or brown, but it can be pink or red. Okay, and I'm just going to show you a quick thing. I have an Instagram account. It's called dermdoc.gen. And on this, I have these quizzes that says, can you spot the skin cancer? And so this is just increasing awareness that some of it is not super obvious. So if you take a look at this person's shoulder, can you just take a guess in terms of which one you think is actually melanoma? So the answer is this one. And then here's what we saw on dermoscopy, and this is why dermoscopy is my third eye. I cannot practice without it. So with the naked eye, I couldn't even see any of these features, but you can see right away, I said, okay, here's a mole that has different colors here. It's a little white here. It's darker in the center and on this edge. And then it has what we call these little pseudopods, these little tiny dots with streaks. And this is a sign of a mole that's growing and can be atypical. So this was an early invasive melanoma that we picked up because he came to a dermatologist and we used our dermatoscope. Okay, so what can I do to take care of myself? So self-skin exams, seeing a dermatologist, and then minimizing risk factors that you can control, mainly UV exposure. So avoiding tanning beds and using sun protection. So self-skin exams, do it once a month. Go into a well-lit room in front of a full-length mirror. Use a handheld mirror for the hard-to-see locations, and try to examine all your areas: your palms, soles, nails, scalp, as much as you can anyway, ears, nails, back. And look for the ABCDEs that are obvious. And then again, using a family member to check areas that you can't see. Next one is examinations by specialists. So obviously dermatologists will do a full skin exam, and depending on what your risk factors are, it'll be once a year, it'll be every 6 months, every 3 months. And sometimes somebody comes in and we're like, you're good, you can come back in 3 years. So, and then ophthalmologists are important. So we talked about ocular melanoma. It can occur in the eye. So getting an exam, at least at baseline, and then somebody can say, okay, you don't have anything, you don't have any risk factors, come back in 5 years. If there is a mole that's noted, then a lot of times they'll want to see it back in either 6 or 12 months. Gynecologists are important. So we know that melanoma can occur in the vulvar and vaginal area. So if you have a gynecologist, have them check there, or have your dermatologist check there. Dentists to look all inside your mouth and examine that carefully, because mucosal melanoma can occur there as well. And then hairdressers are actually very helpful. So they can actually, in your appointments, look through your scalp carefully and then tell you if there's a lesion that you should have checked out. And then I'm going to say, basically, I brought this up because, again, not everybody needs a total body skin exam once a year. They actually have modeled out that if every single person got a skin exam once a year, it would take 40 hours of a dermatologist doing skin exams to pick up one skin cancer. So it's actually not practical for everyone to get a skin exam every year. But if you have these risk factors, then you should get a skin exam. So large number of moles, fair skin, history of sunburns and tanning, personal history of having an atypical nevus, personal history of any skin cancer, and a first-degree family member with a history of melanoma. So a derm exam, basically looking you over head to toe. Our job is basically to determine what is a normal nevus, what could look irregular, in which case we will biopsy it to make sure it's not melanoma or something that's severely atypical, and then obviously picking out what is melanoma. And then this is what we call a dermatoscope. So again, I mentioned this, it really helps us to have detailed visualization of the structures of the skin. And again, another example of what we can see on the dermatoscope. And then some people with a large number of moles, they will actually have something called total body photography, where we actually have them get undressed and we take digital photographs. And then if they actually get it done again, it can actually lay it on top of the first set and help us as dermatologists to figure out the ones that are changing or new. And then this is, I have 3 minutes left, so I'm gonna go over what you can do in terms of sun protection. So basically using a daily sunscreen that's labeled as broad spectrum, which will cover both UVA and UVB sun rays. The sunscreen should be at least SPF 30, and keep in mind that on your face and head and neck and ears, it should be year round because we get sun throughout the entire year, and the UVA rays come our same intensity all year round. So we have seen patients get sunburned in the middle of winter. So all year round, and then during the summer and the spring, especially when the sun is out, then you put it on the areas that are not covered by clothes. SPF 30 really is our minimum, so it screens out 97% of the UVB rays as opposed to 93. And then you can see that as it goes up, it's actually only minimally more effective, so like 98%. But interestingly, it has been shown that if somebody uses SPF 100, they do have lower risk of sunburn compared to SPF 30. And the main reason is everyone under applies. So if you under apply SPF 100, it's better than under applying SPF 30. So that brings us to basically how much. So this is another factor. A lot of people under apply sunscreen. So you should be applying a full shot glass full, which is 1 fluid ounce, to all the exposed areas of your skin. So if you're wearing shorts and a t-shirt, it should be a 1 fluid ounce for every application. So that 1 bottle of sunscreen should only be lasting you 8 applications. So if you have the same one from last summer, you're not using enough. If you use a spray, you really want to make sure you're doing an even sheen. So we actually say use 2 to 3 passes. My personal feeling is that I don't like the sprays, to be perfectly honest, because I think people don't use it adequately. And then 2, I don't want to know what we're going to find out in 20, 30 years of all the stuff we're inhaling. I'm being totally truthful. So I say stick to the lotions and creams. The other thing is reapply every 2 hours. That's the other thing that people don't do. They put it on in the morning and then they get sunburned late in the afternoon. So just keep it on you, reapply every 2 hours. And then just going back to, what is the best sunscreen? Honestly, there are chemical sunscreen filters, what you see up here called oxybenzone, avobenzone, and then there are physical blockers called titanium dioxide and zinc oxide. Both of them are totally effective. There has been some evidence that the chemical blockers can be absorbed and detected in the bloodstream, but we don't know if that means anything right now. So at least right now, it's not showing that it's dangerous or cancerous, but it is a fact that it can be detected in the bloodstream. So I personally tell my patients, for kids and patients who are pregnant, just stick to the physical blockers that don't get absorbed into your skin. And then if you are concerned about it, just stick with the physical blockers. Seek shade between 10 a.m. and 2 p.m. Those are the peak hours. And then just remember that's not just sunscreen. It's using long sleeve shirts and pants, and there's a whole line now of SPF built into these clothes and swimsuits. And that can be a great way so that you don't have to worry about reapplying. And then wearing a broad rimmed hat, because that's better than a baseball cap, or because it just helps to protect the ears and the neck. And then don't forget your sunglasses, because we see a lot of skin cancer occur right on the eyelid margins where you can't put sunscreen. I have 3 girls. These were when my oldest 2 were young, and we would bring our own SPF tent to the beach, and this was all of them in, this is them in all SPF swimwear. So I practice what I preach. And thank you. I'm happy to take questions at the end. Yes.
All right. Good afternoon, everyone. My name is Jeff Wayne. I'm the Chief of Surgical Oncology here at Northwestern. And I thought I would focus on a little bit on the surgery that's related to melanoma, but specifically talk to you a little bit about sentinel lymph node biopsy, a technique that really revolutionized the way we've cared for patients with melanoma. I'm going to move these myself. Okay. So what is sentinel lymph node biopsy, and what is this concept? The concept of sentinel lymph node biopsy is that not only will a particular lymph node basin accept drainage from a particular area of skin, but a specific node in that basin will be the first one that takes the drainage from that area, and that's called the sentinel node. So as you can see, and I don't know if I have, here we go. So if this is the injection site of the radio tracer or the blue dye, when it's injected, it usually will typically go to the first or one lymph node in that basin, or it can go to multiple basins like we see here. And why is that important? Well, it's important because the status of that lymph node will, in a lot of ways, determine not only what the prognosis is for a particular patient, but how we treat them. Now, just looking at the audience, I think a lot of you will be able to recognize who this gentleman is. I show this to younger audiences, and they look at me with a blank stare. But this is John Wayne, who was obviously an actor here and did a lot of kind of cowboy westerns. John Wayne did not die of melanoma. He actually died of gastric cancer or stomach cancer, and he was cared for by this gentleman, Don Morton, who is a preeminent oncology surgeon in the United States and was the chief of surgical oncology at UCLA, and took care of John Wayne and through his illness. And Don Wayne's family endowed Don Morton with what is called now called the John Wayne Cancer Institute, which was set up in Santa Monica and allowed Dr. Morton to carry on numerous important landmark studies, including two that I'll discuss today related to melanoma. And Don was truly a giant in this field, and we owe a lot to him. But again, in terms of sentinel lymph node biopsy, the concept here is that regions of the skin have specific patterns of lymphatic drainage, not only to the regional nodal basin, but to a specific node, the sentinel node in that basin. And obviously, the status of the sentinel node, or what we've discovered is the status of the sentinel node reflects the status of the nodal basin. And so if you can take out just one node or two nodes, as opposed to what we did in the past, which was electively remove whole basins of nodes, this can be done with less morbidity to the patient and obviously at less cost to the healthcare system. What makes the sentinel node technique or what makes it different? Well, not only do we typically, in a typical nodal dissection, the pathologist will cut the node in half. They'll do a slide of each side and look at them. In the sentinel node biopsy, we actually do serial step sectioning of each node and do special stains, what's called immunohistochemistry. A couple of them are over here, HMB45, Melan-A, MART1, S100, can be done to prove that, the cells that are in that node either are or aren't melanoma. And so the technical components of this procedure, it's done in the operating room. It's the patient goes to the nuclear medicine department in the morning and gets what's called a preoperative lymphoscintigraphy, technetium 99. 5 millicuries, about the amount of radioactivity in a chest X-ray, are given into the skin around the biopsy site. And the sentinel node is then localized using not only a handheld radioactive probe, but also a blue lymphatic dye that gives us visual clues and allows us to take out those specific nodes that we need. This is what a lymphoscintigraphy looks like. It's kind of like a Rorschach test, but if you can imagine on the left, that's a patient with their arms up. They've been injected in the flank, and what you start to see first in the right upper area here is the first axillary sentinel node. But then later as we look at a side view, you can also see there's a second node that turned up here in what's called an in-transit node. In other words, there can be nodes that are between the nodal basins, and it's just as important to take those out. So who gets a sentinel lymph node biopsy? So as I mentioned, after Jen or someone like Jen diagnoses a patient with melanoma, she makes a decision. I either can take care of this in my office, or someone like a derm surgeon or a Mohs surgeon can handle this, or I need to send them to Jeff for consideration of sentinel lymph node biopsy. So in this day and age, and with current guidelines, typically it's what we would call anyone with a T1B melanoma. In other words, greater than or equal to 8 millimeters in Breslow thickness, or with ulceration. There are other kind of more minor factors that we sometimes look at, especially with younger patients, so age younger than 40. A lot of those patients will err to the side of performing the sentinel lymph node biopsy, or when the patient has a high number of mitoses, which are thought to be a marker of more aggressive behavior, we might consider sentinel lymph node biopsy in those cases. Similarly, patients who have an unknown thickness, for instance, if an outside dermatologist does what's called a shave biopsy and then transects the melanoma at its base so that the deep margin is positive and we're close to that 8 millimeter kind of number, we might offer a sentinel lymph node biopsy. Or if there's distorted pathology, in other words, the specimen comes out in fragments, or sometimes in these ambiguous diagnoses of melanocytic lesions, the so-called Spitz lesions, or typical Spitz lesions, which can look like what's called a spitzoid melanoma. If we're having trouble determining which of those we might be dealing with, then we'll occasionally perform a sentinel lymph node biopsy to help. Again, these are typically young patients, and to help clear up the diagnosis and what the treatment plan should be going forward. So this is how this looks in the operating room. Your left upper, the image in the left upper side, so this is our initial scan. This is our gamma probe. We know this is in the axilla. We'll make a very small focused incision. We'll look for the blue dye. We'll come down to the node. We'll take the node out. We'll go back and rescan the basin and take out additional blue nodes, or any node that has within 10% of the highest radioactive count. So let's say the first node had a count of 1,000. We'll take out any node that has 100 or greater, but leave anything less than that behind. And again, the average number of nodes taken per basin is somewhere around 2. Sometimes it's 1, sometimes it's 3. It's rarely more than that. I put this up here because just to show you what, kind of the extent of dissection that we used to do. So this is a patient who has an inguinal sentinel node, but the line you see drawn here, this is the incision we would typically do for a full inguinal node dissection, and we would take out all the nodes from over here to what's called the adductor muscle, out to the sartorius muscle, and up over the inguinal ligament. So, before this technique of sentinel node biopsy, this is what we'd be faced with doing for all these patients, and basically would, in about 80% of the cases, would not find any nodes that were positive for melanoma, only in about 20% of the cases. So, again, this has been a technique that's really revolutionized how we treat patients with melanoma. And again, here's this inguinal case. You can see the blue channel leading into the blue node, and we take that out and send that out as our sentinel node. So why is this important, or how do we now use this sentinel lymph node, or why do we even use it in the way we treat melanoma patients now at all? And the first trial that looked at this, again, was run by Don Morton. It was a multi-institutional international trial that enrolled patients from all over the world, and basically they randomized patients with intermediate thickness melanomas, meaning about 1 to 4 millimeters. I think it was 1.5 to 4 millimeters in this study, to either get a wide local excision only, the red arm, the wide local excision plus observation, versus 60% of the patients underwent wide excision with sentinel lymph node biopsy. If the sentinel lymph node biopsy was negative, they were observed. If the sentinel lymph node biopsy was positive, they underwent an immediate completion nodal dissection, meaning we took out all the nodes after about 2 weeks after that initial operation. In the observation group, patients were followed clinically without imaging, just by physical exam, and if they had a palpated nodal recurrence, they then underwent completion nodal dissection at that time. Now, if we look at all the data, in other words, the whole group, there wasn't a big survival difference between sentinel lymph node biopsy and watchful waiting. However, if we looked at this group, the group that underwent that had positive nodes, okay? So in other words, either detected by sentinel lymph node biopsy in the green arm or detected at a later time in the red arm, the watchful waiting arm. What we found is that patients who underwent sentinel lymph node biopsy had a better survival. So there seems to be something about getting these nodes out early and doing more surgery, at least at this time, that made a difference. Now, obviously, in this day and age, we have immunotherapy and other effective adjuvant therapies we didn't have back then. And so, again, it calls into question what we're doing surgically. Now, the second trial, the MSLT2 trial, that was done by the group at the John Wayne Cancer, or led by the group at the John Wayne Cancer Institute, was a trial to understand whether we really needed to do this bigger completion nodal dissection after a patient had a positive sentinel lymph node biopsy. So most of the patients entered right here, and from MSLT2 centers, and were accepted into trial because they had a positive sentinel lymph node. They were stratified and randomized to either undergo a completion nodal dissection, that much bigger operation with its, intended complications and things that can come from a big operation like that, versus just follow-up of the basin with the regional basin with an ultrasound. Now, that's the difference between MSLT1 and MSLT2. These patients underwent what we call active surveillance, and this has become the kind of standard of care now. And so in another example of what we would call surgical de-escalation, we're now doing less surgery. And why is that? It's because in patients who underwent observation versus completion nodal dissection, and this is the important group if you look at a disease-free survival, red versus blue, or probability of distant disease-free survival, there was no statistically significant difference between the two groups. So in other words, you were doing an operation in about 80 to 85%, if you did the operation in 100% of people, you're really only benefiting 15 to 20% of the people by detecting other potentially positive nodes, but you were doing a big operation that didn't benefit 85% of your population. So again, in 2024, why do we do sentinel lymph node biopsy? Well, one, it allows for complete nodal staging, which allows patients to enter clinical trials who are truly staged appropriately. But perhaps more and you're going to hear Sue and Jeff talk about this down the line, but perhaps more importantly, we now truly have effective therapy for patients with stage 3 disease. In other words, patients who have positive sentinel nodes. We don't do more surgery on them now, which is what we were doing after MSLT1. We now do less surgery. In other words, we don't do the completion nodal dissections, and these patients go on to receive, adjuvant, and in this day and age, usually adjuvant PD-1 inhibitors or adjuvant BRAF MEK therapy, which has been shown to be effective in patients with stage 3, especially stage 3 and B and C disease. So, in this day and age, it's really become important as a surgeon to know who to operate on and when to operate on them as opposed to just operating, and it really dates me back to a point, and Jeff will remember these days where sometimes good surgery is all we had, but, that's really not the case anymore. And now we're raising the specter of what's called the MSLT3 trial, which will be a trial of neoadjuvant therapy, in other words, therapy before surgery, and then deciding whether we need to do the big operation again, like we would normally do in those patients, or whether we can do a more selective operation, what we call a selective lymph node dissection in some of these patients. So, it was John Wayne himself who says, tomorrow hopes we have learned something from yesterday, and I think that's where, these clinical trials really come into play, and I think we've learned a lot, and I don't mind the fact that I'm doing less surgery in this day and age. In fact, I hope at some point I'll put myself out of business, or someone will put me out of business. But anyways, I just want to thank you all for listening, and I think we're going to do questions at the end. Is that right, Sue? All right. So I think we got to keep us on time, and I will turn this over to Jeff.
I can see how you can confuse the two of us. Hi, guys. Good morning. It's really nice to see all of you guys joining us on a Saturday morning. I see a lot of faces that I recognize and I care about. There's a birthday out there. They shall remain unnamed, but thank you for spending your birthday at our melanoma school this morning. So I'm Sunandana Chandra. I am a medical oncologist, and I have the privilege of working with Jen, Jeff, and Jeff, Padram, and Lila, and we're very proud of our melanoma team. So I have the, I think, somewhat daunting task of chatting with you guys about whole body or systemic therapies. And I want to show you some data to kind of help you guys understand how we think of things. But I'm gonna it's gonna be a little bit of a whirlwind, so forgive me. Okay, so first of all, if you look at this little guy, this is how we all started, right? And on the dorsal or the top aspect of it, there's a neural tube that goes all the way down. And that neural tube depicted in orange here is what gives rise to melanocytes. And from melanocytes, melanoma forms eventually. And these melanocytes make up our neurons, our cartilage, our bone, our connective tissue, all the organs, with the biggest organ being skin, right? So this is an explanation of why melanoma can really occur anywhere, it can metastasize anywhere, etc. Oh boy, I'm doing something wrong. Okay, so this, the development of these therapies that are known as immunotherapies that I'll get into much more detail about. I mean, this was absolutely revolutionary. It changed the way we treat melanoma first and foremost, and then subsequently it was then approved in many other cancers, but melanoma was the first. And because of the development of these immunotherapy drugs in melanoma, Doctors Allison and Honjo actually won the Nobel Prize in Physiology because they identified these immunotherapy, what ended up being immunotherapy targets on the T cell, which I'll get into. I'm going to kind of skip over this because I'm not going to pretend like I'm a dermatologist like Dr. Choi, but Jen's pictures, I hope, gave you kind of a flavor of what different melanomas can look like. Now, today we'll be really focusing on data from cutaneous melanoma. However, there are other subtypes, acral, which is kind of a subtype of cutaneous that Jen talked about, also mucosal, where it occurs in the sinonasal passages, gastrointestinal tract, vulvovaginal tract, genitourinary tract, conjunctiva, and then uveal or ocular melanoma. But today we're really going to focus on cutaneous because that's where the bulk of our data lies. So I'm going to walk you guys through this. This is the cancer immunity cycle. So this is how our immune system should be working naturally. So at the bottom, imagine that's a cancer, specifically melanoma in our case. On the melanoma, our natural immune cells act upon it to try to kill it. It's a very non-specific antigen, what we call antigen independent. It's just our immune cell kind of recognizing in general that these cells are foreign, they need to be killed. Now, when that happens, those killed cells then release a lot of what we call neoantigens depicted in these little red dots. Those are picked up by antigen presenting cells, another immune cell that's this green blobby type cell. That antigen presenting cell picks up those melanoma neoantigen cell bits and then travels to a lymph node. In the lymph node, that antigen presenting cell presents those melanoma bits, those neoantigens, to the T cell. The T cell depicted in blue are the soldier cells. They are what we call our effector cells. They do the primary damage to the cancer. So you got to activate those T cells. Those T cells then go through the blood, back into the tumor, and then they identify the melanoma and kill it. this is how our immune system should work. However, it doesn't always work this way, right? Now, in order to augment this cancer immunity cycle, we've developed we meaning the scientific and medical community, have developed all kinds of drugs to try to make this cycle work better. Example is chemotherapy, radiation, targeted therapy, basically kill more cancer. And then you have vaccines and GCSF and TVAC that actually acts on those antigen-presenting cells. And then you actually have immunotherapy medicines that act on the T cells. So that will then take us to what systemic therapies or whole body therapies do we have at our disposal right now? You guys have all heard of chemotherapy. It's it's traditional therapy that we used to use in melanoma and really no longer do. A, it doesn't work. B, it's very non-specific. There's a lot of toxicity. When you stop the chemotherapy, the effect wears off. And usually the cancers usually develop a resistance to the chemotherapy. But most importantly, in melanoma, it just doesn't work. It's still a mainstay of treatment in many other cancers, though, just not so much in melanoma. Then you have targeted therapy. So these are usually, maybe not always, but usually they're pills. They could be IV medicines, but they directly target a molecule or a receptor, usually on the cancer cell, to kill it. An example of that is for patients who have a BRAF mutation in their melanoma, you can use a BRAF inhibitor, a BRAF targeted therapy to kill the melanoma. And we'll get into that a little bit longer. Now, what's the beginnings of cancer immunotherapy? So Dr. William Coley, he's known as the father of immunotherapy. He was in late 1800s. He was the first to recognize that for his sarcoma and lymphoma patients, when he injected bacteria into those tumors, the tumors actually shrunk. Now, he didn't quite know what to make of it, but it was the first recognition that there's something going on with cancer and infection and our immune system. Now, what do we have as part of our armamentarium right now for melanoma? So we have these immunotherapy drugs, many of which you guys have heard of, pembrolizumab, Keytruda, nivolumab, Opdivo, ipilimumab, Yervoy, the combination of ipilimumab and nivolumab, the combination of nivolumab and relatlimab. TVAC is not really an immunotherapy drug per se. It's a special category called an immunomodulatory drug, which basically means it may not be directly targeting the T cell like these immunotherapy drugs do, but it can still affect our immune system in a meaningful way. And then you have these targeted therapies. In melanoma specifically, the way we use targeted therapies, the most common is a person has to have a BRAF mutation. And if they do, then we have a number of targeted therapy combinations to try to treat that person. So let's talk about this. This is going to look like a very busy slide. I apologize. But remember I talked about that green blob? So that here is depicted in this light blue. That's the antigen presenting cell. Also, you can think of it in some respects, in some instances, I'll describe it, take the place of a tumor cell. And this orange is the T cell. Remember, that's the soldier immune cell that we're trying to activate. So what happens is these T cells, when they're activated and they're back to fight the cancer, they actually automatically express negative or inhibitory receptors. Examples of that is CTLA in this aqua blue, or LAG3 in this yellow, or PD-1 in this purple. When these T cells express those inhibitory receptors, those receptors bind their partner either on the antigen presenting cell or on the tumor cell itself, and it shuts the T cell down. So this is a way that the tumors use to protect themselves against the killing effect of the T cell. So in order to stop that, we use these immunotherapy drugs to bind these receptors. So ipilimumab or Yervoy binds this teal receptor. So it's called an anti-CTLA-4 antibody. That's what ipilimumab is. Pembrolizumab or Keytruda, nivolumab or Opdivo, it binds this purple receptor. And then Opdualag binds this yellow receptor. And by binding it, it prevents the receptor from binding its natural partner, thereby keeping the T cell active. So in the world of cancer, remember, we want those T cells to remain active. And so we use those immunotherapy drugs to help keep those T cells active. But we don't get something for nothing, which I'll talk about a little bit later. The other thing I wanted to say is it gets so complicated so quickly, you guys, because right now I just talked to you about PD-1, I talked to you about LAG-3, and I talked to you about CTLA-4, because these are the approved immunotherapies that we have in melanoma. But look at all these receptors that are out there, whether it's on the T cell, whether it's on that antigen-presenting cell, whether it's on the tumor cell, whether it's on inhibitory cells called myeloid-derived suppressor cells or cancer-associated fibroblasts. There are so many ways that our immune system and our body have developed to shut down these T cells. And so we're constantly battling how to keep those T cells active so that our cancer can be killed. Another mechanism that we use is people who have a BRAF mutation. So this is, we call this a signaling cascade. This is the MAP kinase signaling cascade. So what that means is these are all enzymes, you guys. And so the RAS kinase enzyme causes a domino effect on the RAS kinase enzyme, causes a domino effect on the MEK kinase, ERK kinase, etc. And then that allows the melanoma cell to grow. That's the problem, right? So in a person with a BRAF mutation, this signaling cascade, this domino effect, is constantly active. So it results in melanoma growth. So what we have done, again, we meaning the medical and scientific community, have developed BRAF against this RAF kinase and MEK against this MEK kinase inhibitors. So these are pills that you take that basically these inhibitors can bind to these enzymes and stop the signaling cascade, thereby stopping melanoma growth. So this is the way we use targeted therapies. Last slide was immunotherapies. I'm going to briefly kind of walk you through what we call high risk or stage 2 or 3 melanoma. And then I'll walk you through stage 4, because that's really what we see, what Jeff Sossman and I see as medical oncologists. So stage 2B, 2C melanoma, these are the drugs in purple that are approved. Or of course, we always encourage a clinical trial to see if we can do better than the approved drugs. And then in green for stage 3 melanoma, these are the drugs that are approved or have shown promise. And then of course, the clinical trials always recommended, because we always want to do better than what's standard. You guys do not have to memorize this. I'm not going to quiz you over this, but I wanted to show you what we look at. This is the kind of data that we look at before recommending to our patients what we think could be a potential right option. So these are 3 different trials, Keynote 054, Checkmate 238, and Combi-AD, all of which showed that either immunotherapy, single agent, or targeted therapy, the pills, are better than placebo when given to a person after surgery. So after they've been diagnosed by Jen, and then they get surgery by Jeff Wayne, then they come to me and Jeff Sossman, and then these are the drugs that we've talked about, that we then talk about. So the person has gotten their melanoma removed, their primary spot, they've gotten their sentinel node removed, and then these are the drug options that we have. Now, even though this is not FDA approved, I think this is worth mentioning. So there is a scenario where a person might come to us with a big, palpable, or what we call feelable, that's what palpable means, nodal mass. It could be in their neck, in their axilla or armpit, or their inguinal nodes or groin. So in that situation, a sentinel node is a moot point. We already can tell that those nodes are positive, right? And so for that situation, we might actually recommend or discuss this approach, neoadjuvant versus neoadjuvant-adjuvant. So what does neoadjuvant mean? It means therapy before surgery, and adjuvant means therapy after surgery. So this trial, which we had participated in, showed that in patients who come in with a palpable nodal mass, wherever it may be, they were randomized to going straight to surgery with someone like Jeff Wayne, or Jeff Sossman and I would give them 3 cycles of immunotherapy, then they go to surgery with Jeff Wayne, and then we give them more immunotherapy post-surgery for a total of about a year. And guess what? We don't have to be a statistician to see that the survival who got neoadjuvant therapy first, actually, they had better survival. Okay, that's what this blue line is showing, that the survival is much higher than those who did not get neoadjuvant therapy first. Okay, so then what about unresectable or metastatic melanoma? We actually have a number of options. We've talked about immunotherapy, we've talked about TVAC. It's a therapy where we inject directly into the melanoma for that subset of patients who may have a melanoma on their skin or in their subcutaneous tissues. We're not going to be able to inject TVAC into the liver or into the brain, right? So it's got some limitations. And then, of course, we've talked about targeted therapy. What we haven't talked about is at the bottom, which I'll get to in just a sec. It's called cell therapy, or it's the newest kid on the block. It's lifileucel or TIL, which I'll talk about in just a bit. So we kind of went over how these immunotherapies work, how we're trying to target all these receptors on these immune cells. And then this is the data that we look at. So when we tell you guys, there's survival difference, this is the data we're referring to. I am so sorry, guys. That is way too small to see, but let me run you through it. So in this trial, for example, patients were randomized to receiving nivolumab alone, ipilimumab alone, and nivolumab plus ipilimumab. And long story short, the survival of patients who got nivolumab or nivolumab and ipilimumab did better. Those are the patients with the red line and the green line. As you can tell, they're higher on the graph, right? Their survival is better. The problem is, guys, we don't get something for nothing. And so we always grade side effects. Instead of saying, oh yeah, they had a bad rash, we say they had a grade 3 rash or a grade 4 rash. So grade 5 is actually death. And so if I say that someone had a grade 3, 4 side effect, that's a profound side effect, right? And if you look at these numbers on the top right, look at the grade 3, 4 side effects. Oh gosh, you guys, I made a mistake. My bad. So Ipi-Nivo, the grade 3, 4 side effects is actually 55%. That's a typo. Nivolumab alone, the grade 3, 4 side effects is 16%. And then ipilimumab, the grade 3, 4 side effects is about 27%. So my point is, yes, 2 drugs might be better than 1. Yes, these drugs are very effective, but they can have profound side effects, which we'll talk about in just a sec. This is another trial. It showed that nivolumab and relatlimab, shown in the blue line, is better than nivolumab alone. So basically, targeting 2 receptors on that T cell is better than targeting 1. And however, the grade 3, 4 side effects is about 19%. So we don't get something for nothing. And then finally, you might say, well, Sue, what about patients who have a BRAF mutation? How do you choose between immunotherapy and targeted therapy? This is the trial that answered that when someone has a BRAF mutation, this trial actually randomized those people to getting targeted therapy first, or half of them got immunotherapy first. and at time of progression, they crossed over. Okay? And basically it showed that people who got immunotherapy first did better. And so even if someone has a BRAF mutation, we first try to see if we can control their disease by immunotherapy. And oftentimes, if we can't, we might have to add targeted therapy later on down the road. These are some examples of patients of mine. Actually, this particular person had these, so I'm going to orient you guys. So imagine this person lying on this table, feet towards you, head away from you, looking up at the ceiling, and I'm chopping them like an onion, right? So this is a CT scan showing the middle of their chest. So these are the great vessels in the middle of the chest. And this is a nodal mass right here. And then this big organ right here is their liver. And you can see these light gray masses are pretty big. So this person came to me with metastatic melanoma to the lymph nodes in their mediastinum, which is the cavity in the middle of their chest, as well as their liver. And after 3 months of immunotherapy, I don't think we have to be a radiologist to see that this nodal mass is smaller and these liver masses are smaller. Okay, we kind of talked about that already. So when do I use a BRAF/MEK inhibitor? So for example, this is an example. This is a person that I took care of. Person had severe bony pain, feeling unwell, had unintentional weight loss. We did a PET scan, we did a biopsy of their bone, and it was BRAF mutation positive. And they're requiring round-the-clock pain medications. And in general, their functional status is poor. And this is an example of their PET scan. So all the orange, the bright, well, I should say bright yellow should not be there. So for this person, we actually opted to treat them with BRAF/MEK inhibitors to give them the potential for a quick response. One thing I did not mention is that BRAF/MEK inhibitors, although they haven't shown to be beneficial when compared head-to-head with immunotherapy, they are very effective in reducing disease quickly. Compared to immunotherapy, that might take weeks to months. And then these are examples, actually. Each twosome is an example of a person's PET scan who got a BRAF mutation before and after 15 days. So for example, let's take this example. I mean, look at this person. This is a huge amount of melanoma in their abdomen and pelvis. And on the right, you can see it's much, much decreased. Or this person, this is a huge amount of just subcutaneous melanomas all over. And after 15 days of a BRAF inhibitor, it's much, much less decreased. So these are examples of how these therapies can work. Now, I'm going to quickly spend some time on this because I'm running out of time. Okay, TIL therapy. It was just approved a couple months ago. So what is TIL therapy? This is tumor-infiltrating lymphocytes. The name of it is called lifileucel. So what happens is a person has had to have had prior immunotherapy, prior BRAF/MEK therapy, if they're BRAF mutated. Then they come to us saying, you know what? I'm interested in TIL therapy. So then we have to do a number of tests, we have to repeat scans, and we have to see where exactly in their body the melanoma is. Then we have to involve Jeff Wayne, or our surgical colleagues that Jeff works with, to say, this person has metastatic melanoma, surgery is not an option, but can you give me a little piece of their melanoma? Can you take out a piece of it? So then Jeff Wayne takes them to the OR, takes out a piece of their melanoma, and then we send it to a lab. In the lab, they basically chop up the tumor and they remove the T cells from that tumor and they grow it in a petri dish, basically. About 4 to 6 weeks later, those T cells that came from that patient is now ready to be given back to the patient. And then those T cells are then shipped back to us. We bring the patient in. This is where the process gets tricky, you guys. The patient has to have what's called non-myeloablative lymphodepletion therapy. So they get chemotherapy for about 7 days to kind of get their bone marrow in a position where they're ready to accept those T cells. Then those TILs, or those T cells, are given back to the patient, and then it's followed by a very toxic medicine called interleukin-2, or IL-2. So it's just a one-time shot. If it either works or it doesn't. It's not the easiest regimen to tolerate. Interleukin-2 requires a center to have an ICU. Your blood pressures can plummet. It can be a significant endeavor. So it may not be right for everybody. It's also not right now, at least, for people who have brain metastases or people who are functionally maybe not as active or just frail to begin with. Because this is a therapy that is absolutely very, very intense. Okay, I'm going to quickly show some pictures, you guys. So when we activate those T cells sometimes get confused, and they can infiltrate just regular healthy tissue. And that's where we see these immune-related adverse effects, or IRAEs. So it can affect any organ of your body, any itis you can think of, dermatitis, hepatitis, colitis, pneumonitis, myocarditis, any itis you can think of, these immunotherapies can cause, okay? The onset is very unpredictable. You need to follow up patients very, very closely. You need to diagnose this toxicity very quickly. You got to figure out, okay, am I causing it with the medicine, or is there something else going on that's causing these side effects? Do I need to start the person on steroids, pills, IVs? Do we need to admit them? Do we need to give them medicines on top of the steroids? Now, why do we give steroids? Because those T cells are confused and they infiltrate healthy tissue to cause side effects. The steroids then calm those T cells down. So then people do worry about, if you're giving me steroids to calm my T cells down, what's going to happen to my cancer? Studies have shown that people who have had an immunotoxicity-related adverse event, their survival is actually better than people who have had no side effects, number one. Number two, if they've required steroids, their survival is better compared to those who have not, blue versus red. And number three, even if we had to discontinue therapy, their survival is the same. So in general, it's not so bad if we have to treat someone with steroids if they're having a side effect. It's much worse if we ignore it. So these are examples of severe rashes on the left, or severe colitis. This is the inside of someone's colon who's getting colitis from the immunotherapy that we're giving them. These are examples of someone who developed their pituitary basically shut down. So here, it actually shows an enlarged pituitary. And if I were to take that out and look at it under the microscope, it would be filled with T cells. Those T cells aren't supposed to be there. They are just confused and they infiltrated the pituitary instead of the melanoma, or possibly in addition to the melanoma. In the middle, this is an example of a myocarditis. This is the wall between ventricles, and it's very thickened. That shouldn't be happening. And on the right, this is an example of hepatitis, where the liver gets inflamed from these immunotherapies. And that's what all these little purple dots, these are all immune cells that really shouldn't be there. And then this is an example of a person of mine. This was her lungs at baseline. Middle is lungs on immunotherapy because she had pneumonitis. Right is after steroids. Her lungs got much better. And then pneumonitis, and I just wanted to show you guys in general, can look very variable. So you gotta go to a team where they have the expertise to be able to diagnose these. And we actually have an immunotoxicity consult service at Northwestern to help manage these side effects if they get so bad that a person has to be admitted. So I just wanted to kind of share that with you. And with that, I will end. I'm so sorry, I'm a little over. Thank you, guys. That I will end. I'm so sorry, I'm a little over. Thank you, guys.
Just a quick story. Isn't she fantastic? And part of why I said that is when I went away for about 3 months, I was afraid all my patients would move to her, but only a few did. But anyways, I'm going to try to go really quickly over some of the things that Sue spoke about, and give some context and how clinical trials fit into everything she spoke about. Okay, so what I'll try to cover is generic, how do drugs get developed? What are the different phases? And I will tell you, in the 30 plus years I've been around, phase 1 studies have changed greatly. We used to give any drug any mouse responded to, and now there's actually some intelligence behind some of the treatments in phase 1. It's all the clinical trials that led to the new therapies, and then a little bit about the future, very little. So how does a drug get developed? Well, nowadays, you know, you have to make it is sort of the beginning, and then you have to look at some model, some mouse, and how it affects the mouse's tumor. And the models are better now. They can recreate cancer, melanoma much better. And then I'll talk briefly about clinical development, clinical approval, and usually most drugs have to be post-approval. They need to have a trial that supports further the development. So this shows the same thing, but sort of phase 1 studies that we do are primarily safety studies. But actually, no drug really moves forward unless there's some signal of efficacy. So, you know, this patient, finding a dose that's safe, if there's nothing else, it doesn't usually go past phase 1. And what we also do is we incorporate those studies with phase 2 studies. And what are phase 2 studies? Those are what I'm talking about. Those are studies that look for efficacy. It's a one-arm study, and all the patients get the right dose of the drug. And again, there has to be some signal that it's working. The third phase is really a lot of these drugs, most of these drugs went through that, and basically the experimental drug that I was talking to has to be compared to a standard drug. Now, in melanoma, that standard drug has changed, you know, incredibly. But, and we don't really do placebo studies. In other words, patient only gets placebo, though it's been done, and probably initially it could have been done because the drug we used is probably worse than placebo. And then I told you about post-marketing. And you can see that we start with 10,000 compounds. Of those, only 250 probably are tested preclinically. And then that number decreases as you talk about phase 1, phase 2, phase 3. And also, and one of the reasons it decreases is cost. The cost of these trials is amazing, even though I don't always try pharma to believe what they say about the cost, but the cost is really huge. So here's my history a little bit, and it's back to the dark ages of melanoma, which I know really well. In 1975, a chemotherapy, dacarbazine, was approved, honestly, I'm not quite sure what study it was. I'm not quite sure. I know it wasn't a phase 3, but there were at least responses. When I initially took a faculty position in 1989, and don't necessarily figure out what that means, there was DTIC. That was it. And then it changed. First, by a mild, minimal amount, interferon alpha 2B was approved as an adjuvant, and that was 1995. The drug that was approved for metastatic disease, Sue just slammed, and she's right, but this drug did probably cure patients, though it made 100% of patients very ill for 1 or 2 patients or a little more improvement. Now, that was up until 2010 or 2000, there were those 3 drugs. So if you had melanoma in 1999, those would be Jeff Wayne doing surgery, Lila, who's here, doing some radiation, though we didn't use it a lot, and the 3 drugs I told you about, which looks incredibly depressing, and it was. Since 2010, 14 drugs have been approved. It's a total transformation of the field. And Sue pretty much covered most of these drugs. I'm certainly not going to list them, but one by one, they got approved. And this is impossible to see. I couldn't find a good slide, surprisingly, that goes up to now. But all of these drugs, one by one, through 2011 and actually 2024, when cellular therapy was approved as lifileucel. I cannot say it. And there probably will be some additional approvals, but not new drugs, I don't think, but new approaches. So the first thing Sue mentioned, so I'm not going to talk to you about it a lot, but another transformative finding, which we didn't know at all, was discovery of this mutation in this one gene, which led to a change in BRAF and led to BRAF turning on this important pathway, and just it basically took it out of standard regulation. And now, as Sue talked about, we have inhibitors, and this is the similar slide, but I just wanted to show you, this is the 3D structure. Why do I show you that? Because actually the drug came, this 3D structure came first, the crystallization. So they figured out from the crystallization whether this would fit into the enzymatic pocket. And that's how the drug, and this is, I'm just pushing this because it's my study. Okay, so over the years, there's been a number of studies. Certainly, the initial one was with Zelboraf, vemurafenib, which is not used frequently, and that's mainly because of photosensitivity, not that it's a bad drug. We then approved combinations, which were dabrafenib, trametinib, Mekinist, and Tafinlar. And then the other combination, vemurafenib, and most recently, encorafenib and Bini, which is Raftovi and Mektovi. That's pretty good. I remembered all the brand name. And then, as Sue mentioned, it then ultimately got approved for adjuvant therapy. There's one thing I didn't mention. There is an approval of use of this immune therapy in combination with atezolizumab, which is an anti-PD-L1. I won't comment on that, but no one uses it. But here's the pathway I spoke about. Here's BRAF in the middle. And all of these other molecules and pathways have been devised that when BRAF accelerates the pathway, they will change and modify and block that inhibition. So the BRAF drugs block the BRAF mutation, and then all these drugs kind of all these molecules come to the forefront and block the inhibitor. And that's why, in general, the durability is not as great. Okay, I think Sue showed this or something like this, and I think it's important what she said about the Yervoy CTLA-4 blockade occurs elsewhere in the lymph node. The cells, T cells have to go to the tumor, and that's where PD-1 acts. And this is kind of another timeline that shows you the approval of these combinations over time. Going on. Okay. I should doing that. Sorry. Okay, let's see if this works. Okay, and she also showed this, the huge number of molecules, antibodies that are here to regulate that T cell response, and certainly the ones that are most known are the CTLA, PD-1, and now LAG-3. But there's a lot of interest in some of the others. Now, the study, findings that showed that ipilimumab, Yervoy, and Opdivo was superior was Checkmate 067. So without this study, we would not have that. This was required to get approval. And as she showed, really the key thing about this is recurrence and this is survival. When I first entered the field, I would tell patients that the median survival was 6 to 9 months. Now, with these drugs, the median survival is about 6 to 7 years, which is really unbelievable. And you can see steadily there's a spread between the combination and Nivo alone. But again, the blue is toxicity, and no question that toxicity with the combination is worse. Now, we've been incredibly spoiled, but not every study is positive. This is a study with a pegylated form of interleukin-2. There was a lot of data from phase 2 studies, so single arm, and everyone was hyped up about it. They did it in a randomized study, and you can see survival was completely overlapping. So not all phase 3 studies are positive, and sometimes we need to do them, or many times we need to do them. So one other drug that Sue didn't mention is a drug for uveal melanoma, which I really mentioned because it's a unique type of drug. It's what we call a bispecific molecule. It binds to your T cells, your immune cells, and the other end binds to an antigen, a very specific peptide antigen on the surface of uveal melanoma. This is actually the only evidence that these bispecific works in solid tumors. And you can see the survival was better than control. Well, what's happened with studies? Well, now studies have moved greatly into the phase 1 and 2 arena, and few phase 3 studies. Most studies, of course, involve stage 4, and it's really a matter of numbers, money, and I don't mean money in a negative way. Where do you put your resources? Where do you put your patient resources, your financial resources? And just to give you an example, we have some studies here in which we're looking at Opdivo and a drug, cabozantinib, which is a drug used in kidney cancer but has effects on the blood vessels, and we're using them in a mucosal melanoma that was mentioned. These types of melanoma respond very poorly. There's a study in China where they see many of them, and it's looked very promising, a similar study. And there's evidence that immune infiltrating cells and high expression of vessels go with a good response to therapy. And so that's a trial that we're looking at. This is another trial, and this is really interesting. It's basically very somewhat similar to what I talked about before. But this molecule actually has CTLA on one surface, or anti-CTLA on one 4, which is Yervoy, and on the other side, there's actually a toxin from Shigella, a very toxic molecule. And what the purpose of this is to eliminate suppressor cells. And so the CTLA-4 is bound by suppressor T cells, and it brings over this toxin. And this is what we call antibody-dependent cytotoxicity, ADC. And these are definitely approaches that have moved to the forefront. Here are some other studies we're doing, and a number of studies. I got this from MD Anderson. Not that I want any of you to go there. But again, multiple studies, multiple disease setting, and those are key. Sue already talked about Lifulosa, and I don't think I have really anything to add. But basically, what is their approval based on? It's based on a response rate, so 1 in 3 patients respond, and the durability of those responses. They stay in remission for 1 to 2 years. Now, what's going to happen with TIL therapy? Well, even now, they're modifying the molecule, the TIL cells, and they're modifying to decrease toxicity and to enhance efficacy. And we have great approaches now. And this basically shows 3 different approaches to make the selection, better function, and less toxicity. And the last thing I'll talk about is on the right side, and this is the use of genetic testing to determine these neopeptides. Then these neopeptides are put into an antigen-presenting cell, and or a virus. And this is exactly how the COVID vaccine. This is no different from the COVID vaccine. And this is the study, and basically it's a small phase 2 study. They're doing a phase 3, and you can see the red line certainly is superior in terms of recurrence than the blue line. Lastly, and I'll finish, Sue already showed this, I think this is a major breakthrough that, again, we needed a study to prove, and that study was simple. You just gave some of the treatment free versus none, and you saw the improvement. Now, in a month, they'll present another one of these studies that's a little bit different. It's a little more complicated, and it uses a different regimen, low dose, IPI, and Nivo. And you'll see the results, but it's a plenary session, so you have to go. I'm sure you'll read about it. And you can see the improvement. This shows you those patients that do well are those who have no tumor and in the resected. So where are we going? I think neoadjuvant therapy in many settings is going to become a dominant approach. So Jeff is going to be put back to work in a number of settings, but we treat them patients first. You've heard about TIL, you've heard about CAR T cells in hematologic malignancy, that's coming. You've heard about bispecific antibodies, that's 1,2Bs, and you've heard about tumor vaccine. These are all areas that we have started and will move into. And then lastly, I think one that is still really in the experimental phase, but we can study circulating DNA from the tumor. So we can know if the tumor is shedding, and that does correlate with the size and the amount of tumor. But we know if the CT scan shows tumor all over the place and it's a little smaller, we don't need the ctDNA to test it. But that isn't always true. And in the adjuvant setting, it isn't true. So I think in the future, this test will be used prior to therapy and during immune therapy to understand what's going on and what the risk is. And I think that could also be a transformative thing. Thank you. Sorry, I went. Oh, now they're on. Sorry.
Well, maybe listening to me will be like a break. So, so I'll talk to you a little bit about genetic testing in melanoma. And but before I start, I'd like to quickly applaud all of you for coming out today. I think listening to a disease condition that maybe has affected your lives in a stressful way can be somewhat of a triggering thing, and I think you're all very brave to come out today and listen and educate yourself on this topic, despite how it might make you feel at times. So my disclosures, and you all probably remember back maybe many moons ago to your first dermatology visit. And part of that is our initial intake. We want to get a good family history and a personal history of skin cancer from you. And sometimes we will make what's called a pedigree or just a family tree. So in this case, what we're seeing here, does pointer work? Maybe I'll just use the mouse. So what we're seeing here is that the shaded in boxes describe people who were affected by the disease. So in this case, they did have melanoma, the squares being the men and the circles being the partner. And you can see that this is their family tree, the first line being their kids. Like, for example, this is a son that they had. This is the spouse of the son, and then this is their kids, and so forth. And you can see that there are a number of family members affected by shaded in boxes of melanoma. So we can see there is a strong family history coming from the father's side of melanoma here. And that kind of can give us an idea of whether a change or a mutation that's present in melanoma. And so Of course, we know that melanomas, or all cancers, typically have genetic changes that turn these cancers on. And so that can give us an idea of whether some of these mutations are inherited, or what we would call germline, like on this side, or if they're somatic, or what that refers to as acquired during life. So on the red side, what you see is this is the initial egg and sperm of the parents that are creating the embryo, and the mutation is there present at the level of the egg. So that means it's going to be carried into every cell of the person's body, and including their, if it's a male, their sperm or their egg, and they'll pass it on to their children. Conversely, on the other side, what we have here is the parents had normal egg and sperm, the embryo formed, and then later during development, could be any time after the embryo is formed, or what's most common in the case of melanoma, during your lifetime, most likely through ultraviolet exposure, you acquire the mutation. And then that would not be an inheritable thing then, right? So how much of melanoma is thought to be familial or heavily inherited? Well, we generally think about 10% of melanoma patients have a strong family history. And there's a number of, actually, we're discovering more and more genes that are relevant for that, but a significant proportion of those strong familial melanoma genes are related to two genes, one called CDKN2A and another one called CDK4. They probably constitute 40% of this 10% familial melanoma. And then there's about 60% that are a number of other genes. Now, when you do inherit a gene that predisposes you to melanoma, we kind of divide these genes into different types depending on if you get that gene, how likely would it be that you would then get melanoma? So if it's very likely, we call that a high penetrant germline mutation. And some of the ones that we deal with a lot, but are not limited to these, include the CDKN2A gene, CDK4 gene, and the BAP1 gene. With CDKN2A, if you live in the US, your lifetime risk for melanoma would be about 70%. If you lived in Australia, it would be close to 99%. So it's always a combination of your genetics and the environment. And then there's this gene CDK4. And an important thing that we're going to talk about a little bit is with each of these genes, there tends to be some other types of cancers that are associated. So if you have the CDKN2A gene, that also predisposes to pancreatic cancer. If you have the CDK4 gene, that gives you risk for pancreatic cancer, gliomas, which are a type of brain cancer, sarcomas, breast cancer, and colorectal cancer. And then BAP1, that leads to uveal melanoma, melanomas in the eye, mesothelioma, which affects the lungs, and renal cell kidney cancer. Okay, so why screen, or why test people? What benefit would it bring to you? Well, I'll go through a couple different type of examples, and the first one we'll talk about this BAP1 syndrome, because we follow a lot of patients, probably more patients anywhere in the country who have this condition. And when you have this, these are the other conditions that you're predisposed to. I listed them here on the right for you. And I think something that's important is that if you look at the age of onset of these different tumors that they are predisposed to, for example, let's look at the mesothelioma. Mesothelioma, the average age of onset is around 60. Renal cell carcinoma is in the 50s. Now, these patients also with BAP1, in addition to skin melanomas, which come on a little earlier than the renal cell or the mesothelioma, they also get these type of skin tumors called BAPomas. They're just a very distinct type of mole that they get. But the point being that these come on at an earlier age than some of the other things, like, for example, the renal cell cancer. So if we can identify you by finding a BAPoma, or you've had a certain number of cutaneous melanomas in yourself or your family, we have a little bit of a head start there to start some type of screening regimen. When I get a BAP1 patient, I'll typically refer them to our colleagues in nephrology or the kidney doctors so they can screen them for renal cell cancer. And if I was fortunate enough to identify the patient while they're in their 30s or early 40s, I've got a head start there, and we've got a chance to detect their other cancers at an earlier time point, and particularly and specifically have a chance to cure them of those other conditions. So that would be one of the main reasons why we would do that. I'll give you one more. Before I start talking about this next slide, I would give you one more reason, is that once we identify a patient as having this syndrome, it also will inform us about their family members. So the genetics team here has a really nice program, and one of the things that they offer is, for example, if you are identified as having one of these genes, they will send a letter confidentially for you, so it doesn't have your personal information, doesn't describe who your name or who you are, but it'll just say someone in your family was identified as carrying this gene, and if you would like, we could test you and your family to see if you have it, and that way it has a chance to protect the family members without giving up the confidentiality of the known patient. All right. Now, who do you test? Okay, that would be another question that comes up a lot. So we have some different rules to help us decide that, because if we just tried to test everyone, our experience would be that it would be like an exceedingly low number of patients, maybe 1 in 1,000 that we would find that has the CDKN2A mutation. So how do we identify who are good candidates? So some of the criteria we look for in looking in that family tree or that pedigree is, do we have an individual with 2 primary melanomas, or 2 first degree, or they've had 1 melanoma and 2 first degree family members with melanoma, or 1 melanoma and 1 pancreatic cancer in the family, or an individual with 3 primary melanomas, typically before the age of 35. I would say a simple way that we look at it that can just keep it simple is the rule of 3s. And what that would mean for CDKN2A is that if you have between the patient and first degree family members, which would just be mother, father, brother, sister, or your children, right? And if you have between the patient and the first degree family members, 3 melanomas or melanomas and pancreatic cancer adding up to 3, then that would be a good candidate to test, where there would be some likelihood that they would be positive for this gene. So that gives you some ideas of what we look at when we're deciding who to test. Now, another question, of course, would be, is there any benefit to these additional screenings? So we identify you, we test you, we find you have the gene. Is there a benefit to then screening you for these other cancers? Well, I'll give you one example. So we talked about how the CDKN2A gene predisposes you to pancreatic cancer as well. So this is a study, and there's a lot of things written here, but I'm just going to kind of describe it more simplistically. They basically identified patients who carried the gene, the CDKN2A gene. And at the time when they identified them, none of these patients had any known pancreatic cancer. Then they started a screening protocol of doing MRIs to test the pancreas or to look for any evidence of pancreatic cancer in part of the group. And then the other group, they didn't have any screening MRIs. They just kind of reported any symptoms to their doctors. And what they found was that basically, in the end, when they looked at the patients who had this screening done regularly, 7% of them were found to have pancreatic cancer. And when they compared the outcomes of the patients who underwent screening to the ones that did not go through MRI screening, at 5 years follow-up, there was 24% survival, which is actually quite good for pancreatic cancer for the patients that underwent screening. And in 75% of those patients, their tumors were caught at a resectable stage, whereas in the patients who didn't undergo screening, it was only 4 to 7% survival at 5 years. So there is some evidence for these different cancers too, that if you do undergo these enhanced screening protocols, that might improve your chance of detecting your other cancers early and potentially improving survival there. Okay, so we kind of talked about this already. So I'm going to move on from there because we kind of talked about the high penetrant genes. Now, we also have mid-penetrant and low penetrant. And the mid and low penetrant, particularly low penetrant, we don't really test for those very frequently. They're actually more common. But for example, low penetrant has a lot to do with the type of skin type that you have, whether you tend to tan easily or burn easily, whether you tend to freckle, whether you have red hair and your eye color. So when you are exposed to ultraviolet rays, okay, and the reason I'm explaining this is because it relates to the genes that are involved. When you are exposed to ultraviolet rays, there's a part of your brain called the pituitary that is involved in hormonal control. It starts to release a hormone called alpha MSH, or alpha melanocyte stimulating hormone. And this is a big protein that then will be released, and it is cleaved into several parts. And one of the parts is this beta endorphin. And that beta endorphin actually gives you somewhat of a high. And that's actually one of the reasons that tanning can actually be physiologically addictive. So if you ever talk to people who tan a lot or get a lot of sun and they tell you, man, I feel so good and I love the feeling, well, there is a true physiologic addiction that comes with that. And so one of these low penetrant germline mutations is this gene called MC1R. This gene will play a big role in what your skin color or skin type is. So this gene is on the surface of cells, and that alpha melanocyte stimulating hormone, which comes from the pituitary, acts on it. And depending on what type of MC1R you have, you might make more of this pheomelanin, which has more of the reddish color, or if you have more of this eumelanin, you make more of a brownish, or you have a darker skin color. So this pheomelanin is just less protective of ultraviolet rays. So one of the reasons we don't really test for it much is because we can kind of just look at you and talk to you and ask you about your skin type and your skin color. And that can kind of explain to us quite a bit about what might be going on at that level. But if somebody really wanted to know, we could actually, there are those tests available too. So this MC1R here, again, this is a gene that is what we call a low penetrant, can have a low penetrant germline mutation and affect you, your skin type and have you slightly elevated risk of melanoma. In general, melanoma affects about 1 in 40 Caucasians, and the high penetrant, so that's like a 2.5% lifetime risk for Caucasian populations. The high penetrant may make you have more than 50%. Mid penetrant may be 20 to 50, and low penetrant just may make you twice as likely or 3 times as likely as the general population. So that's a little bit about MC1R. So I'll end there, but there's basically 2 other things I want to comment on quickly. One is that you shouldn't ever worry about your health insurance being an issue. That's a question that a lot of patients have. Will I lose my health insurance if they find out that I have a germline mutation? And you are protected from that through the Affordable Care Act. But even if that were to get repealed, there's a separate law called the GENE Act, which far predates the Affordable Care Act. And the GENE Act is specifically for genetic conditions and protecting your health insurance. So you cannot be denied health insurance for carrying one of these genes. The other question that comes up a lot is life insurance. That can be a real issue. You may be denied life insurance or have a harder time getting that. if you're a carrier for this. So that's a concern that comes up. Thank you. I'll end there.
Hi, guys. So we have a favor to ask. We would love for you to hear Dr. Pierman and Dr. Garzai speak, and then we were going to have a mock tumor board and some patient stories where patients kind of share their stories with you guys. The thing is, some of our faculty have some other commitments, so is it okay for me to ask you guys to take a quick break, perhaps 5 minutes, maybe stretch your legs, run to the bathroom, and then we'll start in 5 minutes. I hope that's okay. Thank you so much.
Hey, everybody, can you hear me? Great. Thanks so much for having me. This is a great turnout, and I'm honored to be invited to be here with you. So I'm Tim Pierman. I'm a clinical psychologist here, and I'm the director of the supportive oncology program. So I'm going to be talking a little bit today about both supportive oncology and also palliative care. So I'm going to start out just by sort of explaining exactly what is supportive oncology and what is palliative care, and then also talk a lot about kind of how these two programs really collaborate to help with the care of our patients here. So supportive oncology. So our program here, and this varies center to center, but here at Northwestern, we have an interdisciplinary program. So it's psychology, psychiatry, social work, dietitians, we have a tobacco cessation specialist, we have an acupuncturist, a massage therapist, so a whole bunch of different disciplines that really our focus is to provide both psychological care and also really kind of practical support and assistance for things like transportation issues, insurance problems, quitting smoking, kind of promoting health behaviors, those kinds of things. But our ultimate aim, obviously, is to improve quality of life for both patients and families. Now, palliative care is not so dissimilar, honestly. It's another interdisciplinary specialty. In their case, they have palliative medicine physicians, nurses, they have chaplains, social work, and oftentimes they'll have other specialties as needed as well. Their focus is really on relieving symptoms, and that's both symptoms of cancer, but also symptoms of the treatment of cancer as well, because as probably a lot of you know, a lot of the therapies that we use come with their own unique set of symptoms and problems. But again, the aims are exactly the same in both programs. Our aim is to really improve quality of life for both patients and families. So palliative care, I just kind of as a disclaimer, I think a lot of people are scared of palliative care, quite frankly. When I bring it up with patients, oftentimes the first thing I hear is like, whoa, I'm not ready to go to hospice. Like, this isn't the end of the line here. And I think that's really, like, in a lot of people's minds, palliative care and hospice are sort of the same thing. And so this can seem really scary. And by its definition, palliative care does imply that there's a serious illness that can be life-threatening. And so that is really frightening. But if you ask any palliative care provider, they will argue that they should be referred to much earlier in the process, because basically palliative care can be provided in parallel with the regular treatment of melanoma or any kind of cancer. And so the argument is that really people should be referred early on in their treatment for the most part, because both cancer and treatment come with some side effects. So how do our programs work together? First of all, we kind of focus on three areas here. So the assessment and treatment of both physical, psychological symptoms and practical support. Both programs are interdisciplinary and really focus on improving quality of life. And the ways that we do this vary, obviously, person to person, family to family. But some of the things that are really important that I think kind of span like every patient's care is advanced care planning. So talking about sort of the treatment that you're on, how that's affecting you, but also how that fits in with your goals of care. Where do you place the aggressiveness of treatment versus maybe having fewer symptoms or side effects of treatment? So kind of talking about you as a person or the family unit as a unit, and how do you want to approach your care. And this can really assist patients in making very difficult decisions about what kind of care do you want to get? What are you comfortable with? What are you not comfortable with? And so your palliative care team and your supportive oncology team can be kind of right by your side to try to help facilitate those really difficult decisions. So I thought maybe it would help to kind of give a little bit of a representative example. So this is a patient who was diagnosed with melanoma 7 years ago. Unfortunately, 4 years ago, the cancer metastasized and it was found in her spine and her pelvis. So at that point, she began seeing a psychologist to treat her anxiety that was expectable as a result of this diagnosis, and also to help her manage fatigue, so to come up with some behavioral ways, exercise and other things of managing fatigue. And at this point, she also consulted with one of our social workers because she was having some insurance problems and also some issues with transportation. She lived about 30 miles outside of the city and didn't have a car, and so was having difficulty getting into the city. So the way that we kind of collaborated is Julia obviously continued in treatment. She was having, at this point, chemotherapy, immunotherapy as well, and then occasionally she would have radiation therapy as different bone metastases would pop up. Her cancer pain did cause her to have some problems with walking, and her treatment also made her tired. She mentioned that she was a smoker and that she would like to quit, so we referred her to our tobacco treatment specialist. And ultimately, at this point, when she began having a little bit more pain, she was referred to palliative care to manage some of her pain complaints. So she had an initial consultation, and then follow-up, she would meet with her palliative care team every month or two. And I should mention, too, a lot of these visits can be done remotely. They don't necessarily have to be done in person, so it kind of minimizes the burden on patients, since, you know, as you all know, this place can become a full-time job. So both supportive oncology and palliative care, we like to do a lot of things by telehealth if that's okay with the patient and the family. So palliative care started out with helping come up with some medications for pain. She was also having some insomnia, so some medications for sleep. And also she started an antidepressant that helped manage her anxiety as well. So in addition to this, obviously, both palliative care and supportive oncology, we had a lot of talks about how did some of these new treatments affect her physical functioning, how did she feel about being on some of these newer therapies, and also just listening to her fears about her illness, her fears that the illness would progress. And she also was a pretty religious woman, and so she oftentimes would pray with the palliative care chaplain. So I hope that gives kind of a little bit of an overview about how our two programs really coexist and collaborate. But what we know from the research in supportive care, and I will say supportive care just broadly, we know that patients who are referred for any of these supportive care services have better symptom management. So less pain, less nausea, better sleep. We know that patients also really benefit psychologically. So less depression, less anxiety. And one of the things that I think is maybe most important is patients also report that they feel that they have a better understanding of their illness and what's to come. And I think that's some place where supportive services can really, again, kind of parallel your treatment with your oncology team. Because, I mean, I'm sure everybody, you know, has had the experience of coming in and you just feel like you have 100 questions and you don't always have the time to get those questions answered, and then you leave feeling like, oh, what, I don't even remember what we talked about. So it can help to have sort of a dedicated space where you can talk with another medical professional and have a little bit more carved out time to sort of to understand and talk about your feelings about what's happening with care. And so the ultimate thing that has been shown is that supportive care really results in better overall quality of life for patients and families. So again, palliative care would argue that they should be referred to probably much earlier than they typically are. If patients are referred later in the course of their care, there can be persistent unattended symptoms, there can be more pain, more distress. And finally, if disease does progress and patients end up being referred to hospice care, that can feel really abrupt. It can feel like, you know, patients are kind of being cut off from their treatment team. And I've heard people say, you know, I feel like my doctors have given up on me at this point. And so patients who were referred earlier, it can be a much smoother transition and doesn't feel that same way of just abruptly, you know, starting something new. So just to kind of continue with this one patient example. So after 8 years of treatment, ultimately, Julia's cancer did unfortunately become more aggressive, and it spread despite being on multimodality treatment. She did continue to get treated. She continued to see her oncology, supportive oncology teams, and palliative care teams. And the palliative care team was very effective in terms of managing her pain. So she had very little pain, even though the disease had progressed. She also did begin receiving acupuncture, which kind of helped with the pain as well. And finally, she joined what's called a meaning-centered psychotherapy group. And meaning-centered therapy is something that was pioneered at Memorial Sloan Kettering in New York, and it really focused initially on people who had incurable cancer. It's now spread so that it's anyone who has any kind of cancer can participate in these groups. But it really focuses on helping people to figure out what is it in your life that gives you meaning, that gives you joy, that gives you happiness, and how can you continue to do those things for as long as you have, if it's weeks, if it's months, if it's years, if it's decades. So she joined this group and found that very helpful. And slowly her goals sort of changed in all the work that she was doing, from saying that I want to beat the cancer, I want to be cured of the cancer, and she kind of shifted to saying, okay, I want to maximize my time. I want to spend as much of whatever time I have to doing things that give me joy and that bring me peace. So I'll end just with this quote. So some of you may have heard of Dame Cicely Saunders. She was actually a social worker and a nurse. She was British, and she founded the very first hospice in the late 1960s, and she really is truly responsible for solidifying the concept of palliative care and the importance of that in our medical culture. And so I like this quote from her. She said, "You matter because you are you. You matter to the last moment of your life, and we will do all we can to help you not only to die peacefully, but also to live until you die." I think that's really the goal for all of us, right? Is to live all the days of our life as long as we have. So thanks for having me. And,
Hello, hey, I'm Lila Garza. I'm a radiation oncologist here, and I will be talking today about introduction to radiation oncology. So I kind of structured this talk. The first half is just sort of some generalities about radiation, and then I have a couple of specific areas that I think are interesting, that are very pertinent to melanoma, that are a little bit more specific, and I'll go over some trial data. So, that's my outline. So first, I always like reminding myself that when we're thinking about our tools and ways that we can fight cancer, we have this sort of plethora of different things that we can do to fight cancer, all of which have a different purpose. So radiation's in the middle because it's the most important in my world, but I think of radiation as really like a local or loco-regional therapy. And what I mean by that is it's specifically targeted at a cancer or nearby, and it does all of this work in that local area. We think of surgery in that same way as well. You cut out the cancer, maybe you take out some nearby lymph nodes, but it's also local regional therapy. I usually think of systemic therapy, whether it's immunotherapy or chemotherapy, as something that works all throughout the body. So it's something that you either, take a pill or gets injected and works everywhere on cancer cells all throughout. When most people think about radiation, they think about all this scary stuff, right? The atom bomb, the Hulk, there's great show called Chernobyl that came out a couple years ago. And I actually get patients, even now, just on Wednesday or Thursday, I was seeing someone for a skin cancer on the face who was saying, am I going to get really sick like they do in the movies? Am I going to lose all my hair? Am I going to feel awful when I'm getting radiation? And the reality of it is that true sort of medical radiation use is completely different. This is what it looks like in a radiation room, appreciating for those of you that have had radiation. Each room is a little bit different, but this is an example of what we call a linear accelerator, or a LINAC, which is a machine that we use to actually deliver radiation. We have patients sit, there's a bottom right picture there. You actually kind of lay on something called a couch or a sort of a table, and the machine itself actually moves around you. So in the middle fuzzy picture, you can see that the machine does a lot of the work of rotating in different places or rotating around you. And then within the machine is sort of where all the magic happens. So we have electron guns that kind of shoot high energy electrons that then create X-rays that then get pointed to where the tumor actually is, or the area we want to treat is. There's also a couple just for you to be aware of a couple other different ways that we can deliver radiation to that are less common for melanomas, but in case you've heard them, there's something called brachytherapy, which is in the middle, which is a way of directly delivering radiation, typically used in things like prostate cancer or cervical cancer. And then there's something called superficial radiation therapy or superficial x-rays. That's usually the advertisements you see from dermatology clinics, or I think in Florida there's also some vans that drive around with these machines in them that can deliver radiation for some skin cancers. Radiation really works on the DNA of cancer cells. So we know that what makes a hallmark of a cancer cell is that it forgets to play nice with its neighbors. It forgets to stop growing, forgets to share nutrients, it forgets to quite frankly, just play nice. What we do with radiation is we actually deliver the radiation pointed at a particular location. It interacts with all the water that's normally in our body because we're composed of mostly water. It then splits the water atom in something called radiolysis, creates free radicals. That's stuff that causes wrinkles also. So it creates free radicals. And those free radicals are actually what go and cause damage to those tumor cells. And that causes the tumor cells to not be able to grow. Things that can interfere with radiation, so any kind of chemo that interferes with cell growth, that splitting action, so that's how radiation works. Sometimes people get like mega doses of certain vitamins or certain antioxidants. Those can make radiation not work as well because we need those free radicals. And then certain genetic predispositions that can make you not a candidate for radiation as well. My nurse told me I should put these fun facts in here. You're not exposed to radiation when you come into the department. It's only when you're actually getting radiation. The side effects of radiation are very site-specific. So someone who's getting radiation for a melanoma, for example, that went to a lymph node in the neck, has completely different side effects than someone who has like a melanoma of their lower leg. You don't get any hair loss except where the radiation is targeting. So if you're getting radiation on your leg, there's absolutely no hair loss anywhere else in your body. You are not radioactive after you get radiation. You don't have to stay away from people, and you don't have to use a separate bathroom. I guess this is something that we share with patients when they come in. I was not aware of, so I wanted to share that as well. When I think about radiation dosing, so the way that your doctor will kind of talk to you, we use something called gray. And what that means is sort of the biologic effect of the amount of radiation that goes into your body. Sometimes we use centigray or CGY. And the amount of gray or centigrade that you get is really dependent on what the goal of your cancer treatment is. Is it curative? Is it palliative? How much cancer there is? Is there like a big cancer spot? Are we just worried about microscopic disease? And then what we think the sensitivity of the cancer is to radiation and what's nearby, what's important there that we're trying to protect. There's a couple different ways that we prescribe or do radiation. So sometimes it's definitive. And what I mean by that is that there's a cancer there, I'm targeting it, trying to make it go away with no plan for surgery. We don't typically do that in melanomas except very rare cases. Adjuvant, which means cancer has been cut out. We're worried about high risk of coming back in this area, so we're delivering radiation just to that area. That is done in melanoma. And then neoadjuvant, which means, as you heard earlier, neoadjuvant means deliver treatment before surgery to try to either shrink it or make it smaller or make it safer to do surgery, which we don't typically do. And we've heard a little bit about palliative or like Julia, the example in the previous talk. But again, the idea of are we trying to cure or are there some spots where we're really trying to help with symptoms, bone pain, other challenges. I want to quickly walk through what it means when you get radiation. What are the steps? So when you go, you meet with a radiation oncologist, you talk about whether or not you're going to get radiation, and then typically on that day, you're not actually doing anything else other than deciding together that radiation is the next best step. The next thing that we do is we do something called a simulation, or I usually describe this as a mapping or modeling session. You come in, you're literally being a little model for an hour while we figure out how are we going to set you up safely for the radiation. Do we need to use anything to be able to reproducibly get you in the position that we think is the safest? How should we position your arms? Do we need some extra support? Let's say you have a bad back. Do you need some extra support to be able to lay comfortably for a little bit while you're getting the radiation? Sometimes we'll add little masks if it's somewhere in the head and neck area. Sometimes we'll use little like sort of sandbags that we can vacuum into a certain position. All depends on what body part we're treating. Sometimes we will also use some little devices to help push radiation away from nearby structures. So this is an example of something called a bite block. So if we want to treat, like, let's say a melanoma or a skin cancer in the nose, and we want to push the tongue away so the tongue gets less radiation, you can put a bite block in and reduce the amount of radiation to the tongue. So all kind of depends on where in the body we're treating, what we want to shift away, and where we want to shift the radiation to. The next step once you do that modeling or mapping session is you go home and we work behind the scenes. There are a lot of steps between that mapping session and when you actually get the radiation. One of the steps is for us as radiation oncologists to figure out where we want to target. Is there a tumor there? Where is the highest risk area that this cancer is going to come back? And in terms of how we set you up during that mapping session, how much are we worried that you might wiggle a little bit during the radiation? Or how much are we worried about some other body part, like when you're breathing, moving? That is all done by radiation oncologists. This is basically what our residents spend 4 years learning, all these different parts and pieces for every single different type of cancer. When we're actually delivering the radiation, all modern radiation should be delivered in today's era as image guided. So I get that question often. Are you going to do IGRT? All modern, I appreciate that, I can't speak for everywhere in the country, but all modern radiation therapy should be image guided in today's day and age. And what that means is we're using something to make sure that the radiation is pointed in the right direction. So that bottom picture is an example of something called a cone beam CT, which means that we actually get a mini CAT scan before we deliver the radiation, and we make sure that everything looks correct, that everything is in the right position, that the area that we think we're targeting is indeed the same area on your body today, that day that you're getting radiation. Sometimes we'll use x-rays if it's something like a bone that we can see really well on an x-ray, but all of our radiation, at least here at Northwestern, is all image-guided radiation therapy. When you're actually getting the radiation itself, all of our medical specialties all have acronyms and abbreviations that we all like to use that don't make a ton of sense to anyone else. We are guilty of this as well. So the way that you can deliver radiation is either by 3D, IMRT, or VMAT, SBRT, or SRS. These are all different techniques that can be used to be able to get the radiation where we want it to go and protect your nearby tissues. I would like to spend just a couple more minutes on what I called SBRT, just because I'm going to show you some trials in a little bit that really makes this an exciting area for melanoma. So stereotactic body radiation therapy, or SBRT, is the delivery of a high dose of radiation to usually a smaller tumor area, typically given every other day. It's a more modern thing that really has only come into sort of widespread use really in the last 10 years or so. We really required new developments in our technology before we could safely do this. The reason that's exciting for me for melanoma is because we're really learning that even when cancer has spread, either to a lymph node or somewhere nearby, historically we typically thought of those patients as incurable. But we've learned that if you are someone whose cancer has spread to just a couple spots, we can actually potentially treat those spots with radiation and improve outcomes. That concept, or the terminology, is called oligometastatic. And it's actually been done for a very, very long time. So the first report is actually in the 30s of someone getting a metastectomy, or getting a cancer spot that spread from a kidney cancer, removed, and actually living for a very long time. We do this all the time in radiation. So we actually deliver SRS, or stereotactic radiosurgery, to spots in the brain quite often with very good effect. We know that in other types of cancer, if we do SBRT to cancerous spots, we can actually potentially keep people off of systemic therapy or keep them on a helpful systemic therapy for a period of time. We can actually potentially reduce the chance that other cancer spots are going to grow. There have been trials looking at many different cancer types. So the previous slide was just prostate cancer. This is a trial that looked at multiple different cancerous types. And we've also learned, I mentioned this earlier, but we've also more recently learned that we can actually use SBRT to keep people on a treatment like immunotherapy that's working for other areas in the body, but maybe one single spot or one or two spots is growing while everything else is staying the same. We can actually do SBRT to those growing areas and keep you on the systemic therapy that's working for everything else in the body as a way to delay the amount of time or delay the time for which we have to change our chemotherapy or immunotherapy. There's all sorts of new terminologies as we're learning more about this area. You don't need to remember all these, but we talked about oligometastatic, there's oligo-recurrent, oligo-progression, all these new different ways of classifying patients. There's actually a lot of ongoing work trying to figure out how can we categorize patients based on when these spots are popping up, and how do we use that to actually direct radiation appropriately. I just want to spend the last 2 slides or 3 slides talking about proton beam, because I think that's another thing that we see a lot of advertisements for. I think I've even seen it down like on the metro at different stops. So proton beams are another type of radiation. So you can deliver radiation as X-rays, you can deliver it as electrons, you can deliver it as protons, you can deliver it as carbons, you can deliver it as helium. There's a bunch of different things that we can actually deliver the radiation with. Protons are just a different particle. So instead of X-rays, like if you were to get an X-ray or a CAT scan, it's a different part of the atom that's actually delivered. The theoretically appealing thing about protons is that when you look at the way it sort of graphs in your body, it looks quite different from X-rays. So in this picture, X-rays are the green and the red is your proton beam. So it actually sort of puts radiation in the body in a very different manner. And what that means is that the amount of radiation that goes to structures away from where we're trying to treat is actually less. So if you look at the 2 left-sided pictures, this is an example of a pediatric patient with a CNS or a brain and spinal cord cancer. We're trying to aim the radiation in the red, so the brain and the spinal cord, and our standard photons or X-rays, standard radiation, delivers some low dose up into that belly area, which is green, and protons, PR, on the bottom one, actually delivers less radiation to the belly area. This is really critical in pediatric patients or patients that are, still growing and developing. It's still under investigation in a lot of adults because some of that low dose spread we think actually doesn't matter as much in older patients. And there's actually some challenges related to the actual technical planning of radiation that makes it really hard to do well. So we know that that little spot at the end on radiation can actually have different effects depending on what tissue is nearby. So you can accidentally deliver more radiation dose to nearby areas than you otherwise intended to, just because we're still really learning more about those properties and how they work. So, I thought I had another caveat slide. So in general, protons are really attractive, definitely an area of research. In melanoma, I don't think that we necessarily know exactly how to use it, and there are some concerns, depending on what part of the body it is, that it might actually increase side effects. So definitely something worth having a conversation with your radiation oncologist about. They should be bringing it up to you and talking to you about it and saying, hey, especially here at Northwestern, hey, we have a proton center out in Warrenville. Here's some scenarios where we would consider it for you. Here's why or why not. So in summary, we talked about the biology, so how radiation actually works. We saw the technology or some pictures of actual machines. We talked about the steps for the treatment planning, all those little circles. And we talked about SBRT and oligometastatic disease and protons. Thank you very much for this opportunity. I really appreciate it.
So we're going to pivot for just a moment. I've heard some rumblings from some of you guys that it's a lot of information and it's a lot to take, and I'm sure some of you guys are hungry. So what we're going to pivot on is lunches outside. How about everybody go grab lunch, come back, and then on a full stomach we can do a mock tumor board, kind of give you a sense of how our tumor boards go, and share some patient stories, and also give you guys a chance to ask any questions that might come to mind. Thanks so much. Let's go grab some lunch. So as David is slowly setting up, if I could ask my colleagues to join at the table. If you want to bring a bag of chips or something with you, feel free.
I'll try.
Thank you.
Thank you, Doctor.
Sure.
All right, good afternoon, everyone. It really is nice to see everybody here, as was mentioned earlier. I've been looking forward to coming here when Dr. Chandra called me on Thursday and gave me out the invitation. I said yes before she was finished. She could have been asking me to do almost anything around the house, and I would have already been on the line for it. But I really do enjoy coming here downtown. I don't do it as often as I used to, which proves that my treatment has been successful and been working. So I feel humbled and blessed by that. So I'd like to I'm thankful for the opportunity, both for the MRF to sponsor the symposium, for the facilities here for Northwestern. When this first came to me a long time ago, I set the stage early for my melanoma. And in a way, I was fortunate that it was the bad decisions that I made in my youth. Speaking of which, I spent a lot of summers, Dr. Garami, looking for that beach that you had up there on the slideshow. I was unsuccessful, but it was a fun journey. But that journey also led to my melanoma. And because it was mostly, I believe, and my doctors probably agree, environmental in my case. If it was genetic, it may have been more difficult for me to deal with because I would have maybe been trying to blame someone for it, my parents, grandparents, something along the line that I had no control over. But in my case, I did have control over my melanoma. And it was those decisions I made to spend way too much time in the sun. There's a lot of different age groups here. I can see that. Most of my time in the beach did come in the 70s, where it was all about the sun. The advertisements, the media, the peer pressure, and just what we did was get in the sun. We used baby oil, and that's what we did instead of sunscreen. It was not unusual to see people with reflective material pointed towards their faces. A sunburn was a badge of honor. If you didn't get a sunburn, you just weren't playing. So because it was a decision like that, and I was fortunate enough to come to Northwestern, I call it one of the big, when I was looking for it, it was a family decision. I shouldn't ever use the word I, because in my case, it was very much family. My family drove me to come here to get treatment. I waited way too long to do that. And I'm sure glad that they did to get me to come to Northwestern. But in picking up what I call the big four, where I was going to go for that treatment, I did a lot of research. I probably did more than I spent in 4 years of college. And I was very impressed with the team here at Northwestern. When I looked at everybody, they all had about the same tools. They had the same clinical trials, the same machinery, same scanners, but the people were different here, a lot different. And when I see you today, my doctors here, I know that I made the right decision. Dr. Batman Wayne, I remember laying there on the table thinking, what's going to happen? Am I going to come out of the room? And I see you with your bandana, Batman. And I thought, what did I get myself into? But you did a great job, and I appreciate that. So I don't know if I've had the chance to see you since then, but thank you. And it's been that way for all the doctors that I've met. I thought I'd met every doctor in this place, but I can see that I haven't. And but I have been blessed. I feel that I've been able to make the decisions through my doctors' interventions and their education and their letting me know what I can do to make my life better. And to not only say that I'm a cancer survivor, but I'm living now. And that was brought up in a couple slides here. Surviving wasn't good enough for me. And for a while it was. I just sat around and said, I survived. I'm done. And my family said, no, Dad, you're not done. You're not doing the things you used to like to do. You're not enjoying life the way you did. And Dr. Chandra, when she would ask me and quiz me about those C's, she said, we didn't do all this for you to sit at home and just be a survivor. We did all these treatments and spend all this time on you so that you can go out and live, that you can go out and play golf, go to the Morton Arboretum, go to baseball games, have fun with your friends, and do all those things, which I have been able to do because of my great care here at Northwestern. And I just will leave it at that. Thank you all very much, and it's nice to have seen you all.
Can you guys hear me okay? Great. Okay. My name is Brandy Corbello. I was also a patient of Dr. Chandra and Dr. Choi to this day. In 2019, I was diagnosed with stage 3C melanoma, and I was 30 years old, had just moved to the big city of Chicago, took on this big career, and I thought I had this great life, right, coming for me, and then I got diagnosed with stage 3C melanoma. To be honest, like, when I look back in time, can you guys still hear me? Okay, I'm echoing in me. But when I look back in time, I was very vain. It was like the summer of 2019. I was hanging out on the lake with my friends, doing all the things, and I had this mole that I thought was just ugly. So I was very vain. I had never gone to a dermatologist. And I remember that summer, I didn't even know what melanoma was, by the way, but I was like, this thing looks funny to me. I called a dermatologist down the street from where I lived, and I said, hey, I've got this mole, I think I need to get it removed. This is July of 2019. They originally made my appointment for April of 2020. So when I finish this story, like, it's really important to remember to advocate for yourself. A week went by, I was still looking in the mirror, I'm like, I just really don't like this. So I called them again the following week, and I said, will you please get me in like 7 a.m., 8 a.m., whenever you open, I'll walk in, just scrape this thing off. They were like, we don't really do that. And I said, if you don't, I'll go to urgent care and have them do it. So they were like, and Dr. Chandra and Dr. Choi know me enough, like, I push. They were like, okay, lady, we'll get you in. So I went in, they took my mole off. I was like, cool, move on with my life. The following week, I'll never forget, I was in Wichita, Kansas for work. I got a phone call from a Chicago number, which I had just moved here. I answered the phone, and it was a dermatologist, and she said, hey, your mole presented serious, aggressive, like, melanoma. And I was like, cool, lady, like, I'm in the middle of a meeting, like, what do you need from me? Because at that point in my life, I was 30. I'd always heard about my friends getting, like, basal cell or, like, all these things that were, like, non-cancerous. So I was like, why is this lady calling me and telling me I need to go into surgery this week? I hung up the phone. It was a 1.5-minute long conversation. That night, I went home and I Googled melanoma, and I was like, oh, this is like a vibe. It's a thing, you know, like, I should probably call her back. Called her back the next day. I flew back to Chicago. The surgeon I met with at the time told me that the chance of it spreading was like less than 10%, meaning like I would have surgery and I would kind of move on with my life. So I said, is there any way we could do this on a Friday? So that way nobody at work has to know. I'll get my surgery, go back to work Monday, like, no big deal. The following week, I got a phone call after the surgery that it had in fact spread. So they were talking about stage 2C. Stage 3C means it's spreading, and I was like, my whole world just shattered, right? So on the phone, I said, what does that mean? He was like, you're gonna have to move on. The surgeon, right, called me as well. You're gonna have to move on to medical oncology. And at that point, like, world turned upside down. Now this is like October of 2019. So again, like, remember, had I like kept the appointment for April of 2020, likely that was an elective appointment that would have been canceled, and I had stage 3C at the time. So like, I'm like, so I think my biggest like lesson for everybody is like, just be an advocate for yourself, and if something doesn't feel right, even if you don't know what it is, like, always like make that second phone call. Anyways, move forward, right? I did freeze my eggs, which I thought was great. I was 30 at the time, and in the state of Illinois, we have like amazing like health benefits where your company like actually is required to make sure that you are covered for freezing your eggs. I took advantage of that, so I can kind of live my life without having to worry. I moved into medical oncology with Dr. Chandra for 13 months. during that time, Dr. Chandra asked me to share some of this. I went through immunotherapy, nivolumab, so I had 13 months of treatment. My liver enzymes had gone up at one point. We actually took a break in the middle of my treatment. We reset ourselves after 2 months. I went back, everything was fine through the end. At the end of my treatment, I actually presented colitis. Is that what you would call it? Okay. So I had presented colitis. I couldn't eat. This was my last round of treatment, by the way. I'll never forget. It was Thanksgiving. I had gotten Chinese. I had just finished treatment the week before. I was like living my life. I was like, let's go. Got Chinese, and I was getting really sick afterwards. Literally for 4 days, I was like, man, the Chinese really did it for me. I don't know what happened. And then I remember I went to the emergency room, and I was like, there's something like happening in me, right? And I went to the emergency room probably 3 times. The third time I finally said, hey, I'm a patient at the cancer center. Like, could we just call Dr. Chandra and see if there's something going on? Just because they kept trying to treat me with different things. We end up in a message chain with Dr. Chandra, and in fact, I actually had an immune reaction. Like, my immune system was attacking my colon. I was able to get was it gastro, I guess, like the next week. Went in, prednisone did not work for me, so they tried to put me on prednisone to start calming it down. That didn't work, and then I ended up on Remicade, so I finally got through all of that in January of, 2021? I guess I finished all of it, yeah. So, like, fast forward to today, August of this year, I'll be 5 years in remission, which is amazing, yes. Dr. Chandra reminded me that I need to start getting tested for cholesterol when I saw her this week. But I think the biggest thing, like, I'm super grateful for, like, MRF, my doctors, like, super close with them, like, talk to them all the time, and just being able to, like, manage it the whole time. I think COVID presented itself in a weird way while I was going through treatment, but anytime I asked questions, like, everybody was, like, super, like, open to helping me understand what was going on. Melanoma in, like, young people isn't really super, not there, right? So I was, like, kind of, like, isolated a little bit, and super grateful for them, and yeah, it's been great. I've been able to give back. Oh. Dr. Choi's asked me to share what I'm doing now. So I've actually been in the tech world for, 15 years now? It's really sad, actually. And I, just like Ned, got super obsessed with sunscreen. I was also, like, very much a millennial. I will blame myself for my cancer. I went to the tanning bed. You had to be bronze for prom, otherwise don't show up. So I've actually been working with Melanoma Research Foundation, so I do a lot of, like, advocacy around things like sunscreen and tanning beds and telehealth, because I also don't live here anymore, so I'm able to do telehealth with, like, my doctor team. I haven't had to change, but I got super obsessed with, like, what I put in and on my body, because I think the biggest thing, like, when you're going through this is, like, control what you can. Like, you're not going to be able to control the cancer as much as you want to. It's not happening. Like, that's why you have a team of doctors to help you manage it, but you can't control it. So a lot of focus on sunscreen for me, and I just realized in the US we don't have a lot of clean products. If they are clean, they're really expensive, so not super accessible. So I've been spending the last 2 years with chemists and manufacturers on bringing a clean product to market that also gives back a percentage of proceeds to Melanoma Research Foundation, which none of the products do, and focuses a lot on, like, accessibility and transparency into the products, mostly because I will say a lot of the sunscreen products, they're a little dicey, right? A lot of chemicals, a lot of fragrance, and yeah, it actually launches in May for Melanoma Awareness Month, so I'm super excited. It's called Melon, M-E-L-A-N, so short for melanoma, but, like, centered around melons. So yeah. Yeah.
So this is for Dr. Chandra primarily, but how would you treat BRAF fusion melanoma? At yesterday's onco said there were about 15 patients with that fusion gene, and would you go for the BRAF mutation targeted therapy or immunotherapy for that?
So, thank you. So, first of all, I wanted to give a shout out to Nish as well as Alex on the right, we're Howitt and Joey. These four people are intricate in helping us run our clinical trials. So without them, we would not have the trials that we have. So I just wanted to make sure that you guys knew that. So Nish, to answer your question, so the therapies that we have right now is for when the BRAF gene is mutated. So it's not following the typical gene map that it's supposed to, and it's mutated. And what you're referring to is when there's a fusion of two genes. And so, long story short, our BRAF inhibitors are not meant to treat BRAF fusions. Dr. Garami, any thoughts there?
Yeah, I mean, you're exactly correct, because the BRAF inhibitors require this dimerization that the mutated BRAF undergoes, and that doesn't work on fusion. Fusions are very difficult to treat because, and Sue can obviously elaborate on this too, is that one of the things about melanoma is it's the cancer with the most mutations generally, in general, because the UV light is causing so many DNA mutations, and the more mutations you have, then that's the more foreign that the cell looks like, and the better immunotherapy will work, because you have this thing that looks so foreign to the body, right? And the fusions, it's just this one genomic event, as opposed to the other types which have many genomic events. It's just one genomic event that is driving the whole thing. And so the tumor doesn't look as foreign to the body as the other types of melanoma. So I think I was actually asking Sue about this in the off time. We were talking about how some of the melanomas, for example, in the mucosal areas of the body have some similar features in the sense that they're driven by just a few events and don't have high mutation burdens. And they're using some immunotherapy combined with some other kinase inhibitors. So I believe probably some of these cold tumors, still immunotherapy will still likely be a pathway, but they have to figure out how to get more foreign antigen-like expression or how to target that better. But I still think immunotherapy is going to be the way on those. I don't know if you have a different thought or...
No, I think you're right. I mean, sorry. One of the things that Dr. Garami is referring to is if a tumor isn't very immunogenic, meaning it's not really attracting the immune system, then these immunotherapies they're just not going to work, right? So we need to figure out ways for tumors that are not immunogenic. What can we do to make them more inflamed, in which case immunotherapy might have a better chance of working?
I don't need a microphone.
People offline.
Oh.
I had a question about your tumor board patient. Had the patient decided to go ahead with the brain scan and they did find something, would the treatment have been any different?
That's a great question. I mean, generally, you know, we make these we make these recommendations based on guidelines. And sometimes we'll be the first to say that the guidelines aren't very clear. You know, they might say, based on a person's individual case, based on their history, based on their risk factors, you can do a brain MRI not at all, or you can do it based on symptoms, et cetera, et cetera. Now, for that particular case, the thought is, had we been able to catch it earlier, then we could have used other therapies. We could have used stereotactic radiosurgery, or even though it has the word surgery in it, it's radiation delivered directly to the small melanoma. We could use immunotherapy. Immunotherapy has shown to penetrate the blood-brain barrier. But in the case of immunotherapy, it really works well when a person is asymptomatic. they're not symptomatic from their melanoma tumors in their brain. Once they're symptomatic, the immunotherapies just don't work as well. So in a nutshell, yes, I think we could have changed the course of that person's management had we been able to find it earlier.
Excuse myself now. Thank you all. I appreciate it.
Thanks, Dr. Garami.
I have a question about the stage 4 immunotherapy treatments, the Yervoy and plus Opdivo, and then the new treatment of Opdualag. So if a patient has started their stage 4 with the Yervoy and the Opdivo, and then was able to tolerate 2 rounds, and has been on Opdivo 6-7 months, and now they've discovered a new tumor, is there any reason why that patient can't now do the Opdualag? Because I know the medical advice he's receiving is, no, we're going to go back to the Yervoy and the Opdivo.
Yeah, that's a great question. I mean, I certainly can't speak to a particular case, right, as you can imagine, but I think we need to make sure that we're taking the clinical trial data into context. So the data I showed you guys for Ipi and Nivo, or ipilimumab and nivolumab, which is Opdivo and Yervoy, and the data I showed you guys for nivolumab and relatlimab, which is Opdualag, were both technically studied in the first-line setting, meaning those patients had never gotten treatment for their metastatic melanoma before. So I think we have to be careful extrapolating that data into saying that, yes, it's going to work in second or third or fourth-line settings.
And to piggyback on that, I think the idea is we believe that cancers can change over time. So when someone gets a cancer treatment up front, it's sort of acting one way, and then once someone continues and it progresses on those treatments, we believe it changes in phenotype. And so what may have worked in the first line may no longer work because it's now acting more aggressive. It may have different mutations. It may sort of just behave differently. And so what was shown to work when it's in that maybe less aggressive state may not work at all in this changed state.
Isn't that a reason to then do the new one instead of sticking with the other?
So the question is, isn't that a reason to then try the new one? Again, it's a little bit nuanced. So there is data. I didn't get a chance to get into it. It's a Relativity 020 trial that showed when patients had prior PD-1 already, when they were then treated with Opdualag, it just doesn't work as well. So I think we just have to be thoughtful about, does switching them, is it in their best interest based on the data we know?
I have one more question. So given the tumor board, if a patient presents with maybe 2 tumors and it's determined maybe we can do radiation, how close in time does that scan need to be for your tumor board to actually be addressing the current situation? I mean, with an aggressive tumor at 2 weeks, it can be very different.
So the question was, if somebody shows up with 2 tumors, I presume in the brain and or anywhere, and the decision is to do radiation, how soon, when it's from time to decision making, how soon does that scan have to be before we might say, hey, should we repeat scans? So again, a nuanced decision kind of depends exactly where it is. In general, for my clinic, a lot of times in tumor board, we'll use whatever imaging we have. So we'll present the most recent imaging when the patient is seeing me in clinic and when it is time to make the decision for radiation. If it is more than, say, depending on the part of the body, like 8 weeks old for something in the lung, 4 weeks old for something in the brain, often we'll repeat all the imaging before we do our radiation planning scans for sort of 2 reasons. One is just to make sure that there's still a candidate, that nothing's changed. And 2, because we actually want imaging right before radiation to know exactly how big it was, with that idea that, hey, maybe it grew over a couple months, so that when you're done with treatment and a couple months later, we're getting our scans to see how it responded. My personal bias is I want something that looks exactly like it did right at the time of radiation, so I'll often repeat scans But when we're in tumor board, we're using the information that we have available at the time, and typically we're not necessarily saying, we're definitely doing radiation, let's get the radiation process started. Instead, the recommendation is, hey, they need to see a radiation oncologist, let's get them in to see you, and then we'll often order additional things at that time.
Or perhaps at the tumor board, we might even say, you know what, we need a repeat scan. Let's get a brain MRI, let's get a CT scan of the chest, whatever the, you know, the question of, the area of question might be.
I have a very lay question. So when someone undergoes treatment and you're saying, you're thinking that they'll, the likelihood is that they'll have a so long remission, or is that because there are still cells in the body, cancer cells, that the body's immune system without the treatment is handling, and then it progresses and gets to be too much? Is that what's happening?
That's actually not a lay question. It's a question that's at the heart of what we do and what we're kind of dealing with on a daily basis. Your notion is absolutely correct. It's almost inevitable, we think, that there's microscopic melanoma cells floating around, okay? Now, the hope is that your immune system, based on that cancer immunity cycle I showed you, and based on the fact that we've activated T cells with immunotherapy and things like that, that it will identify those floating cells and kill it. But there are ways that the cancer has developed evolutionarily to avoid those mechanisms of trying to kill it. And so that's what we're worried about, is some cell somewhere is going to make a home and then start growing. You're welcome.
Our last question.
In order to take advantage, or if you make the decision that you're going to do the TIL treatment, do you have to discontinue your current treatment for a certain amount of time before that?
So the question was, you know, do we have to discontinue interim treatment or interval treatment while we're preparing someone for TIL, which is one of the therapies that was just approved a couple months ago. On trial, the answer was a clear yes. You could not be on any therapy as you're being prepared for TIL. Okay, but in practicality, now that it's FDA approved, we have a little bit of leeway, and the FDA allows us to make the decision that's right for the patient. So for a particular, you know, to get TIL off the ground and into the person takes a good 2.5 months probably, if you count the echocardiograms, the cardiology evaluation, the stem cell evaluation. There's just so many things that need to happen. So in the meantime, could someone continue their therapy while they're waiting? The answer is yes. The problem potentially is if that therapy causes them horrible side effects, it might delay the TIL. But that might be a potential that we might be willing to accept in order to try to get them closer to TIL.
Well enough to go through it.
Right. If they have a side effect and now suddenly we're like, uh-oh, we can't really give you TIL safely. We got to have you recover first and then consider you. You know, I think on behalf of all of us, it is very clear to us. I mean, the fact that you guys came on a Saturday morning and spent a few hours trying to learn about melanoma and how best you can care for yourself, for your loved ones, it just shows, you know, a level of dedication and interest that is really gratifying for us to see. And we cannot say enough how much I mean, you guys are warriors. The fact that you guys are out there and dealing with this on a daily basis. So our hats off, you know, go off to you, to everything you're doing to try to manage your cancer. And hopefully you guys feel that you have a good support system, whether it's us, whether it's a different team at a different hospital that's providing you the care that you need.
Oh, thank you.
Well, thank you all again for joining us today. If I have not met you already, my name is Miriam Kadosh. I'm the Director of Patient Engagement and Education at the Melanoma Research Foundation. I want to give a huge thank you to our partners at Northwestern for putting on an amazing day today. So we thank you for your partnership. And I want to thank all of you for coming. We are going to be putting up a survey on the screen, which is a QR code. So all you have to do is scan your phone over this screen, over the QR code when it comes up, and fill out the very brief survey to tell us about your experience today. And if you don't get a chance to do it today on your phone, we'll send you an email. So you will get to do that at home. And please visit us online at melanoma.org. If you have any questions for me or the team at the MRF, please do send me an email. It's education@melanoma.org. Thank you and have a great rest of your day, everyone.